Hello, YouTube. Hello, YouTube. Okay, I'm setting up Facebook. We're good with Facebook. Yes. Hello, hello, hello. Hello, my friends. It is Sunday, March 28th. It is time for our support group meeting. It's a little bit late starting it up today because my mom was struggling and we're getting very close to the point of needing an in-home nurse. It is hard. Anyway, so my name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, March 28th. Meeting. The purpose of the meeting system is strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody telling you that there's no hope. I don't want anybody telling you that you are damaged goods. I don't want anybody telling you that there are no treatments. Hello, Lisa. Nice to see you. Because there is hope. There is hope. It's so interesting. I worked, I'm going to say I did 3 or 4 long coaching sessions on Friday and yesterday. And in every single case, we went back and we found pelvic trauma. Every single case. Anne says on YouTube, hey, can you have IC without pain? Absolutely. It's called frequency urgency pressure. Pressure is a really interesting symptom because pressure is something, like I don't think I've ever felt bladder pressure. I have felt pain, but pressure implies a fullness, now I've had a pulling sensation and a pushing sensation, but some doctors think that pressure is just your brain's way of interpreting pain, right? So anyway, listen, we are simulcasting live on Facebook and YouTube. And guys, again, we are working on this damn internet connection. I literally have 2 internet streams. I'm hardwired to AT&T and I'm hardwired to Comcast. And ironically, Comcast has great speeds, but they're the ones who screw up. So I don't know. So for those of you on Facebook, I would really appreciate it if you could just let me know if the stream starts stopping and starting. Carolyn says, hi, Jill. Hope you're well. Yeah, man, I hurt my back yesterday again, and my leg is like kind of numb again. I was out there just trying to distract myself from dealing, with my mother, because obviously she's starting to fail a bit. She wants to sleep all the time and be in bed all the time, and it's getting pretty weak. So we're kind of at a point. All right. Hello, Nicole. Hi, Renee. Thank you, hon. Hi, Cindy. Hello, Annie. So you guys, I've sent out all the free books and I can give you names of who's getting them. But I have one left over. The reason why I say that is because Annie, you're one of the people getting the free books. So Shelly S is getting the free Facing Pelvic Pain book. Kristen C, Cindy S, Paula H, Michael C, Georgia B, Annie C, Lauren K, Debbie P, and then I just found one more right here in my office. We'll go out to somebody too. What is this one? Yeah. Thank you, Carolyn. Hello, Rahul. Nice to see you. Shall have an appointment on the 7th to talk about testing for small fiber polyneuropathy. I think it's a good idea. The reason why, in fact, I was talking to my brother about it because I was telling him he has small fiber polyneuropathy too, just like I do, I'm sure, 100%. And it helps us understand therapies. It helps us understand where you need to invest your money. So if, for example, you are primarily pelvic floor driven, then you need to be spending your money with pelvic floor work, not bladder therapies. If you have central sensitization like I do, chronic overlapping pain condition, small fiber polyneuropathy, then you're going to be doing things that are going to be calming nerves down. And so, back in the old days, everybody thought Elmeron was going to cure everybody. Guess what? It didn't. Everybody thought DMSO would be the wonder drug. Guess what? It's not. Neither one of those are particularly successful. And now we know why, because we've got this such rich diversity in this patient community. We're not all the same. And, I see If somebody says you have IC, what the hell does that mean? It's vague. It's too vague. It's not specific enough. And so I had one patient who she said, well, do I have IC? And I went, well, your bladder wall's healthy. You don't have Hundreds lesions. You have extreme pelvic floor tension, which was confirmed by her doctor and her physical therapist. So if you want to stick with the IC label, I mean, you would be IC/bladder pain syndrome subtype 3 pelvic floor driven. That's the type of specificity we want. Whereas another patient was clearly IC subtype 2 bladder wall driven estrogen atrophy. So the more we know about your anatomy, the more we can find the right therapies for you. Hello, Lori. Is it possible to have IC and pelvic pain? My cystoscopy with hydrodistension showed a red bladder with bleeding cuts. So, Lori, listen, and I have pictures. Hold on. Let me see if I can get my pictures here. So here's the deal. A hydrodistension is no longer required for a diagnosis of IC, nor is it expected. Why? Because we know the test itself can cause redness in the bladder. You know, back in 1987, when the National Institutes of Health created their first diagnostic criteria for IC, not for clinical urologists, but for research studies, they said that to be considered for an IC research study, you had to have Hundreds lesions or a petechial hemorrhaging. But shortly thereafter, another researcher said, well, wait a second. You know, anybody who you stretch the bladder in is going to have petechial hemorrhaging, and they proved it. And so very, very quickly, here's pictures. Hold on. I always have to organize my slides better. So this is one thing. Okay, now these are Hundreds lesions. Okay, this is a big deal. If you got big bloody wounds, look at this big bloody wound right here. Look at this one. And you can see, look, it's known for, it can be described as a crack, but it can also be described as a stellate appearance, like a star. It has a center with radiating red arms. Okay, and look at this one, right? There's one. This one, this is just a super big one. This is a good one right here, right? And this is also a very, very big one. Look at these. All right, Hundreds lesions are a clear disease process. They're IC subtype 1. And when you biopsy this lesion and you look inside the cells, you see massive inflammation, massive inflammation. There is a war happening in the middle of these lesions, a war. And so what is that war? Well, now we have a pretty good suggestion of what that war is, because researchers in Europe found active virus in the urine of patients with Hundreds lesions that was not found in patients who don't have Hundreds lesions. So they found the Polyoma Bk virus. They also found Epstein-Barr, and then there was some discussion of herpes simplex and HPV. But really, the dominant one is Polyoma Bk. Now, Polyoma Bk virus is one we all have. It's not a sexually transmitted disease. This is not about, you know, misconduct on the part of your partner or anything like that. We all have it. It's part of the normal human virome. So we got the biome and the virome, right? And so normally it's quiet. It gets turned on when somebody's immune compromised. And it's known for causing hemorrhagic cystitis, bleeding cystitis. So if you were going through a kidney transplant, you had to be on anti-rejection drugs. If you were immune compromised with not COVID, but CVID, or if you had HIV, something like that, where your body was really struggling with something, that's when the polyoma virus turns on. And I mean, we knew that 5-6 years ago. We've been waiting for our own National Institutes of Health to make a comment on the European researchers. And they too finished their virome study last year, and they too found a virus in the urine of some of you, not a lot, some of you, you know, like 5%, maybe 6%, if I remember correctly. And so understand that, again, this is why subtyping matters. And now we know why Hundreds lesion patients didn't respond to Elmeron. Now we know why Hundreds lesions patients didn't respond to pretty much every therapy, because for them, it looks like it might be a viral infection. Now, but let's look at this. This is very different, right? These are called glomurulations or petechial hemorrhages. So let's look at them side by side. Are they the same? No, they're not the same. We now believe this is probably caused by the test. So we had, again, I'm going to say about 1990, right around there, we had a researcher who had 50 women scheduled for tubal ligation, asked if he could look in their bladder and do a hydrodistension. When he did that, this happened. And so slowly but surely over the last 20 years, the finding of these has been delegitimized, is no longer considered important. And last year, the AUA, they just threw it out. So this is no longer meaningful right now. All right. So for Lori, getting back to your question, my cystoscopy showed a red bladder, bleeding cuts. We really do believe that that's a residue of the therapy. A residue of the test itself. Okay. Hello, Lisa. Hi, Laura. Hello, Noel. Andrea says, I think a prolapse is making my IC so painful. Is there anything I can do until surgery? Yes, a pessary. What you would do with if you have a prolapse, you would be doing perhaps a pessary until you could have that surgery. You guys were simulcasting live on Facebook and YouTube. If I'm looking up here, I'm looking at Facebook. If I'm looking down here, I'm looking at YouTube. Let me introduce myself. Jill Osborne, president and founder of the IC Network, longest serving IC support group leader in the United States. This will be my 28th year as a support group leader. I bring to you 3 college degrees, a degree in chemistry, a degree in pharmacology, drug development with a 1-year surgical internship, a master's degree in psychology, and my website, the IC Network, was my doctoral dissertation proposal in how to bring support to IC patients who were homebound. Ironically, I was homebound and couldn't do the degree. But I'm really happy that 27 years later, it's still ranked #1 in the world by Harvard Medical School. And I was just published by Harvard yet again. I was the only non-doctor published in the new Facing Pelvic Pain book. And so let's just say I kind of think I've kind of earned a mini doctorate in IC support and IC kind of sort of stuff. So anyway, listen, I'm not a doctor. I can't give you medical advice. My job is to educate you, to empower you, and to kick you in the butt and get you back to your doctors again, right? And with the right questions, with the correct questions. All right. So Becky says, what can be done about viral infection with Hundreds lesions? Well, #1, we have to prove that you got a viral infection. That would be a next generation urine test. And Becky says, why aren't the AUA guidelines for IC updated? They were, the AUA guidelines, the American Urology Association is the largest professional urology group in the world. They have a big annual meeting where 20 to 25,000 urologists from around the world fly in somewhere to the United States, and they have a big meeting. They also dedicate 1 or 2 sessions to IC, so that's where we see some of the biggest research. They came together in about 2010. And they put together a large panel of IC experts and we needed that because patients were being treated willy-nilly. You name it. Some patients were told there were no treatments at all. Other patients were told surgery was the only option, et cetera, et cetera. And so we needed a national guideline that people would follow so that y'all were treated reasonably the same. It was updated in 2014. I do believe they are in the process of updating it again. Dr. Phil Hanno at Stanford is the chairman of the AUA committee. I correspond with him fairly regularly. I don't have any news on the latest update, though. It's going to be really interesting to see what they choose to do. What I like about the AUA guidelines, if you were to look at them, and I think everybody should look at them, if you go to auanet.org, click in the upper right-hand corner on the word guidelines, click on that, search for IC. You can read the guidelines. They're fabulous. Y'all should read them. You should have 3 copies of them. You should print out one for you, one for your urologist, and one to carry in your car if you ever need to go to the emergency room, another doctor, so that you have them on hand. What's nice about the AUA guidelines is they accept and understand that you've been traumatized. God forbid you were diagnosed 20, 30 years ago. They understand implicitly that a lot of patients never went back because the treatments hurt so bad, because back then they were stripping the bladder lining with silver nitrate and fluorpactin. And so goal number one of the AUA guidelines is to not traumatize the patient anymore. They want you to get some relief. Goal number two is if you're not responding to therapy, they don't want you to keep doing the same thing over and over again if you're not getting better. They want you to take a step back, revisit your diagnosis, and let's make sure we haven't missed something, right? That's important. So auanet.org, go read them. They're good. Carolyn says, how much is the book? The book, we don't sell the book. You can get it on Amazon. It's free on Kindle Unlimited. I don't, or you can go to facingpelvicpain.com or .org, facingpelvicpain.org, and you can see all the authors, all the sections, everything over there. Amy says, do most of us with IC do well with statins? Now, Amy, we need a lot more research on that. Some patients do, and some patients appear to struggle with it a little bit. And there's really no way to know until you try it. Cindy said, is it normal to stay on muscle relaxer suppositories as a method to control pelvic floor spasms, or are they intended for a short period of time? That's a great question for your doctor. I have used muscle relaxants regularly for the last 15 years, but not daily. I use muscle relaxants when I feel my muscles get tight and I'm not responding, or they're not responding to what I would normally do, my normal routine of pelvic floor work, which I should have done this morning because I could feel it I could feel the pulling sensation in my vagina this morning as I was laying in bed, and I didn't get out my wand and do it like I should have. I just came off of my longest period of muscle relaxants, which I used for about 2 months, a quarter of a pill, a Flexeril at night, because I ruptured judith in my back and my muscles are still really tight. And I heard it again yesterday. Oh my God. Then my orthopedic surgeon goes, Jill, you have some arthritis in your hip. That might be part of the problem. I'm like going, are you kidding me? Please, God, nothing else. No. I just want a normal freaking year with nothing going on, right? Nothing. Please, nothing. Georgia says, just got your gyne a couple days ago. I have more pain in the pubic area that I never had before. Is it possible? She did a pelvic assessment for my pelvic floor. She said it's fine, but she ordered me hydroxyzine, Atarax, and I don't know how to use it. I'm just using quercetin. You told me right. She found atrophy. She's ordering estrogen cream, which is okay. So the purpose of estrogen cream is that when you give your skin that, your skin will start to produce mucus. It is not comparable to aloe. Aloe can be a barrier, just like coconut oil can be a barrier. It might be soothing, but we're talking about wanting to try to help heal. And one of the ways we do that is we give one of its important ingredients, and that is going to be a little bit of topical estrogen. Topical estrogen is considered remarkably safe. You can just Google it. Google topical estrogen safety, topical estrogen research, and you can read those research studies for yourself. When you use topical estrogen, it tends to stay in the tissue. It doesn't tend to migrate through the body. But ultimately, that's a discussion that you have to have with your doctor. Shell said, I had a guidance culture and it said that it detected a methicillin resistant gene. Does that mean that the bacteria in my bladder is considered MRSA? No, that's a resistance gene. That's a drug resistance gene. That's not identifying bacteria at all. That's just saying whatever it has in there is resistant to methicillin. I have an amylase resistant gene that we found every single time. I've never taken that type of antibiotic ever. ever. I should know. I'm a pharmacologist. And so the only way I could have been given this weird antibiotic that I'm now resistant to, or that I have bacteria that are resistant to, is meat products, or they gave, damn it. Lisa says, I've seen it on, I'm just seeing an Elmer litigation announcement. Have seen it before. It is getting to be a large effort. Yeah, it is. It is. And guys, on the 31st, we are having another Zoom meeting with 3 of the attorneys representing IC patients. It started at, well, let's see, hold on. If you go to the page of IC Network, I have a blog with all right on the front page. Yeah. So our next meeting with the attorneys, so that you can get an idea of what's happening with the lawsuits, is going to be on March 31st, and it is at 7 p.m. Eastern, 6 p.m. Central, 5 p.m. Mountain, 4 p.m. Pacific. And let me just post the blog to it. All right. Hello, YouTube. So YouTube, for those of you who are interested, there's a notice of the Zoom meeting. And guys, I'm going to put that, actually for Facebook, I can't quite do that right now. Hi, David. David, I sent out the books that you bought for patients last week. That was very, very sweet of you. Thank you so much. Dawn says, I'm thinking my chronic cystitis is back. That feeling of nonstop needing to pee. I've been able to hold it for hours until recently. Well, Dawn, as you get older, things change. And as you get older, your bladder isn't able to defend itself as well because your hormones change. Your hormones change through your cycle, and then your hormones will gradually decrease as you get older. And so concept number 1 is, what's your skin like? Is your skin changing? And concept number 2 is, are you exposing it to something that's irritating that you're holding in for a long period of time, like coffee? Because that's just going to create more irritation too, or worse, some sort of chemical injury, like NutraSweet. Are you doing a lot of diet sodas or artificial sugars? Those can cause the equivalent of chemical injuries to the bladder. Oh, I got my teeth. What do you think? Yay! Finally, they hurt though. Like if you do this, I figure that the sockets have taken a beating for the last 3 months, so it's probably going to take a while. Debbie says, I'm postmenopausal. You spoke about estrogen cream. Can you address that again? I have a video on our website called the Estrogen Chat. Okay, so think about it. Your bladder is the only organ in the human body designed to hold toxic waste, right? Because urine is body waste. Urine contains ammonia and urea and all sorts of stuff. So how can the bladder hold ammonia for hours at a time and not get damaged? It's a fascinating question. That's why the bladder is such a cool organ. It does something that no other part of the body does. It holds toxic waste. So the way that it protects itself is with a really thick coating of mucus. Your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. It's a mucus membrane organ. Your urethra is a mucus membrane covered organ. Your vagina has mucus. Your vulva has mucus. And the purpose of that mucus is to protect the tissue. It's a barrier so that irritants in urine cannot reach the fragile cells underneath, and it makes it much harder for bacteria to attach to cells and infect the cells. Unfortunately, that nice thick coating of mucus is estrogen dependent. So when you're young and you have lots of estrogen, you can get away with all sorts of crap because you got a really thick coating of mucus. But guess what? We get older, or God forbid you do birth control, or you have to go on Lupron and that puts you into a chemical menopause, or you have hysterectomy. There's going to come a time where you don't have estrogen and your skin gets thinner and drier and you lose your mucus. You don't have as much mucus. Thus, your bladder's ability to defend itself is now compromised. That is not disease. You have frequent urgency pressure pain because you got freaking dry coffee every day or something like that. So, um, uh, we call that the genito-urinary syndrome of menopause. So sex can become painful, the vulva can become dry, the urethra is often the first part of the urinary tract to start screaming with a loss of estrogen, and it feels like there's a drop of urine stuck in your urethra that won't come out. And then your bladder becomes more sensitive too. Oh, look at that. My thingy fell down. Hold on. Gotta put my sign up. Yes, there we go. Okay, so hold on a sec here. So Bill on YouTube says, I tried taking Bladder Builder and also Cystamin, but you got a flare. Is it a good idea to discontinue these supplements? Is it a good idea to look for other supplements with the same active ingredient? You know, Bill, every supplement has the potential of causing side effects, with the exception of Peora. Peora is the one that's kind of the one that has the fewest side effects. But any of the gut-related chondroitin-based or aloe-based supplements, but especially the chondroitin-based supplements, are notorious for causing stomach upset, gut distress. And you never take them on an empty stomach, especially before you go to bed. You always want to take them with a little food. And sometimes some patients, what they do is they get a new pill, a new bottle of something, and you take a whole dose the first day, and you end up shocking your system. And you can't do that. You have to go slow. So it's really rare that they would cause an IC flare. But if they did, that means that you're sensitive to one of the ingredients. So I would back off on those two products. And they're different. That's the thing, is they're different. So you could look at Bladder Rest, because Bladder Rest is a really clean, pristine formula for people who are super sensitive. Or maybe you could look at instead at Peora. So the ingredient that tends to be the issue is the chondroitin. So that tends to be the problem. All right, guys, give me 1 sec. I hear somebody calling me. Thank you, Gina, for your 50 stars. Give me a minute. I'll be back. Okay, we're good. We're good. I mean, honestly, for the 50 stars for you, so you can donate to us by giving me stars. Hey, how much we got in stars since last April? We got $100. Some people would say, why are you doing this? And that is because I'm a support group leader. That is what I do. That is so, but we do have bills to pay. And so it would be better if you could come on over to the IC network like most people do and become a member so you can get our magazine, the IC Optimist. But anyway, thank you for the stars. I really appreciate it. It means a lot. All right. Lisa says, estrogen cream gave me a growing yeast infections. My gyne switched me to Vagifem. It works great. Awesome. That's awesome. I wonder if there was something in the cream base itself that was feeding the candida. Kind of makes you wonder. All right. You know what? Facebook, you guys are hurting. You know what I can do? YouTube, are you guys freezing on YouTube? YouTube, what's the quality of the stream on YouTube? Any freezing, any weirdness on YouTube at all? I have to wonder if this is a Facebook thing. Lisa, Bill, Becky, Deb, what do you say? Is there any freezing at all? Yeah, so guys, over on YouTube, there are no problems at all with freezing. It's Facebook. Crap. YouTube, Arlene says, YouTube is not freezing. Maybe too many people are using Facebook right now and they don't have the capacity. Oh no, Becky says it's freezing occasionally. So what I can do, you guys, what I can do if you want is I can start up the stream on my AT&T for Facebook, and we can see if it would do that there. If you want, if you guys feel the quality is really bad on Facebook, I can restart the stream on my other computer, and we can do it that way. You just let me know. Chris says, I had an ultrasound and said bladder wall had thickened. I think this is caused by inflammation. It could, if I could get rid of my recurring infections with the bladder. Yeah, honey, your body's wired to heal. Your bladder's wired to repair itself. Your entire body's wired to heal. That never turns off. The challenge is we just get in the way. What gets in the way of healing is acid, right? So if you've got a genuine bladder wall injury and we're trying to help your bladder heal, the worst thing you can pour acid on that healing tissue. It'll never heal if you do that. Georgia says, with IC, is the Pfizer or the Moderna vaccine better? I don't know. Shell says, at the urologist week, they told me that they thought there you might have bladder. They thought that what might be bladder stones are actually phleboliths. Phleboliths. A phlebolith? A phlebolith. Phlebolith. What on earth is that? A phlebolith. Phlebolith. Phleboliths. A phlebolith, and I have never heard that. A phlebolith. Oh, interesting. A phlebolith is a small, local, usually rounded calcification within a vein. These are very common in veins in the lower part of the pelvis. They are generally of no clinical importance. When located in the pelvis, they are sometimes difficult to differentiate from kidney stones. They're small blood clots in a vein that harden over time due to calcification. They're called vein stones. Fascinating. And they are calcified laminated fibrous tissue. Huh. Go figure. With the surface layer continuous with the vein endothelium. Huh. Calcified thrombi. Go figure. I would think that would be a compelling reason never ever to a roller coaster again. You know, like when I was a kid, I loved roller coasters, but I'm more fragile now. I don't want to accidentally dislocate my jaw, whatever. This is why I also won't go ice skating anymore, or even I used to love roller skating, but I don't want to fall and break my hip. I would rather walk or swim. Anyway, Shannon said, did my post go through? I did not see it, Shannon. Has anyone taken Hyprex for UTI prevention? Did you have bladder urethral irritation? That's come up before, Shannon. Let me look at the ingredients again. I might be remember what that was. Oh, methenamine. Okay, but I thought that there was something else in there. Methenamine comes up commonly. Methenamine is used to prevent or control UTI caused by certain bacteria. It is not used to treat an active infection. Other antibiotics must be used first to treat and cure the infection. This medication also contains an ingredient that makes urine acidic. When the urine is acidic, methenamine turns into formaldehyde to kill the bacteria. This antibiotic is effective only against bacterial infections in the urinary tract. So you can see that's a double-edged sword, because if you've got estrogen atrophy, you're going to be acid sensitive. But if you have estrogen atrophy, you're going to be more prone to UTI because your tissue can't defend itself. So most people would first go with a PAC product, either Allura or Prevent. right? Prevent. Is an example of a PAC mannose product. This would not be overly acidic to your urinary tract. So that's probably why, Shannon, you're having some urethral sensitivity. So talk with your doctor and see if it would be okay if you switch to a PAC product instead, and make sure you tell them that you've got urethral irritation, because they might also, if it is estrogen atrophy, they might be able to give you some estrogen cream. Georgia says, I heard in a group that there is a suppository of hyaluronic acid, FDA approved, that can be safer than estrogen cream. The bladder wall. Okay, so the human body does have hyaluronic acid in it. It's in all of our joints. Hyaluronic acid has been injected, like in your jaw joint, if you've got TMJ. So I do believe that hyaluronic acid is also a molecular building block of the bladder wall, along with chondroitin. And so that's interesting, Georgia. That's interesting. I don't know. I don't think I've ever heard hyaluronic acid suppository. Let's see. Let us see. A suppository containing hyaluronic acid, vitamin C, vitamin A, used once daily for 14 days can be effective at what? Okay, that's from, what is that from? Hold on. That is from Johns Hopkins. So, the Johns Hopkins Sjogren's Center. Vaginal dryness in women with Sjogren's occurs in pre and post menopause, yada, yada, yada. Okay. Vaginal moisturizers such as Replens, used 3 times weekly. Moist Again, Vagisil, and lubricant Silk, Luvina, Astroglide, KY, Silk & Secret are over-the-counter products. Olive and vitamin E oils are also simple solutions for lubrication. Vitamin E oil capsules can be oil used in and around the vagina. Drops. The regular use of olive oil as a lubricant will keep delicate tissues soft and supple. A suppository containing hyaluronic acid, vitamin E, vitamin A, used once daily for 14 days, then once every other day, can be effective. That must be very new, because when I was much more involved with the vulvar groups, that never came up. But I can't, I'm fallible just like you guys are. Gina said lots of freezing. Annie, oh crap. Marie says, got my first issue of the IC Optimist yesterday. We'll start reading it tonight. Awesome. Does Claritin help IC? Yes, it can help IC. We have a new article on seasonal allergies and IC in our spring issue, which is now at the typesetter. In fact, it's either going to be this cover or it's going to be a guy. I'm not sure which. I think we're probably going to switch it to the guy because I'm profiling men's stories in this one. But we do have an article in here on seasonal allergies and IC. And basically, you want to try to stay ahead of seasonal allergies. You got to make sure you look at the pollen maps online, pollen.com. And generally, what doctors will suggest that you do if you flare during allergy season is use your antihistamines, whether over the counter or prescription. If you suffer with asthma, they're going to tell you that using Montelukast would be a viable option because that can help with asthmatic symptoms. I think it's very, very important that you have HEPA filters in your furnace and also HEPA filters in your bedroom. Get one of the small that you got to minimize your time outside off before you come back inside. If you've been working in the garden, even take your shoes off. Soledad, hi Jill, what's your IC treatment? You always look, oh honey, thank you. I don't do any active treatments for my IC because my IC is very quiet. What I do is Peora when I start feeling my nerves get sensitive again. Once I start feeling a lot of pin prickling, on my arms, on my legs. That tells me that my nervous system is starting to get amped up. I make sure that I'm taking my B12, and I use Peora palmitoethanolamide. I'm going to be doing a big article on this. Found a new research study that showed that this is actually, PEA has actually been used to help patients with epilepsy to stabilize their nervous system. So I'm really, I think this is the future. A lot of people say CBD is the future. I think PEA is the future. There are so many research studies showing that PEA is effective for neuropathic pain. And we've got the big IC study from 2 years ago. We got fibromyalgia studies. We got sciatica studies. We got epilepsy studies. This is looking awesome right now. In fact, I think every product should have PEA in it at this point in time. Marta says, I get Hyaluril installed in my bladder to prevent UTI. It contains hyaluronic acid. Hyaluril contains both chondroitin and hyaluronic acid. And yeah, that is the best bladder installation that's available in Europe and Canada. Unfortunately, it's not available in the US. Bridget says, chronic inflammation and hormone replacement therapy for 40 years, hysterectomy at age 30, urologist says no cure. Listen, you know, I'm a very, very young age, my dear. And if they took your, it means that you have been in menopause now since the age of 30. And the toll that that takes over time on your body and on your skin and on your mucous membranes is real. And so, do they have you using topical estrogen? Bill says, can men with IC benefit from the use of an estrogen cream? You know, I am not sure, Bill. I honestly am not sure. Bill says, my urgency gets worse through the night. I wake up every 2 hours, and the third time I wake up, my bladder is empty and the urgency is intense enough to prevent me from falling asleep. Any tips? Okay, let me describe a typical bladder wall flare, because I think that's what you're having. So a typical bladder wall flare is you go to bed at 11. Of course, you pee before you go to bed. You wake up 2 hours later. Your bladder feels really full. You go to the bathroom and you pee out maybe a quarter cup of urine. You go back to bed. You wake up 30 minutes later. Your bladder feels really, really full. You go into the bathroom and you pee out maybe a teaspoon. You go back to bed. If you fall asleep, you're up 15 minutes later. Your bladder feels very, very full. You go to the bathroom and you just pee out a drop. And you could strain and strain and strain and not get urine out. The way the bladder wall tells you that it's seriously, seriously, seriously irritated is by giving you a false sense of fullness. You feel full even when you're empty. You feel urgency even when you're empty. David, you should send me, if you can send me a high-res picture, I can look at it and see if I can make it work. No guarantees, but I can try. All right. So, right, Bill. So that Bill says that's how it is for me. So that happened to me as a result of something in the daytime irritating me. And so whether it is tight pelvic floor muscles, just tweaking everything down there, or if it is diet, that's what we would want to look at. And then from a therapeutic standpoint, doing something that would protect the bladder makes sense. And so doing something chondroitin and you're having flares from it. So, that's not necessarily viable for you. What would be interesting actually would be, how about taking a completely separate track and maybe trying Allopath, which is organic anthraquinone-free aloe combined with PEA. And that would calm the nerves in your bladder and it would give you the soothing effect of the aloe, right? So that would be interesting. Lorraine says, is it B12 or B6 good for nerve sensitivities? B12. B6 is neurotoxic. If you do a lot of B6, you're going to damage your nerves more. So it's a B12 deficiency that causes small fiber neuropathy and that sensitivity in those small nerves. Okay, now finally on Facebook, I can give you the link to, did that go? This is the link to the Zoom meeting for Elmeron on Wednesday, and you have to sign up ahead of time. So this features 3 of the attorneys actively working with patients right now. I think between them, they have, I don't know, 30 or 40 cases, probably more at this point in time. And they're taking their cases through state court rather than federal court. So now we've got 2 tracks for Elmeron litigation. We got the federal lawsuits and we got the state lawsuits. Unfortunately, the judge that originally was given the federal, the federal judge that they were hoping they would have, and everybody was excited because she's very pro customer and pro patient. Fortunately for her, she got offered like as an appeals court judge, and so the dropped down to another judge who is not as patient centric at the federal level. So the attorneys have split half and half. Some of the attorneys are staying federal, but a lot of them are going state instead. Laura says, how do I find this live event on Facebook on my laptop? If you just go to the front page of the IC network, there's a blog. It's the very latest blog we put up, and the link will be there. God bless America. I cannot believe what's happening with Facebook. YouTube, guys on YouTube, are you seeing freezing on YouTube? All right. So normally when I do these meetings, I do a 30-minute lecture, and rather, lecture stretching it. Rather than doing that, I wanted to, where is it? Here it is. You know you're a geek when you get medical journals. When you get medical journals and you actually read them. It always breaks my heart to put them in the recycle bin, but you get so many medical journals. It's like, oh my freaking God, I cannot read all that. This medical journal had, I thought, a very interesting article that I thought would relate to some of you guys. So hold on a sec. Let me find it. And yet there was another one. Vaginal estrogen is a first-line therapy for recurrent UTI infections in postmenopause women and the risk factors for needing additional therapy. Hold on. So again, and for the gentleman out here, please be patient with me because I've got several articles on men in my latest magazine. I've got 3 really, really good. But, that's where the sexes have different conditions. E487, where the hell is it? What do they mean, E487? E? What does that mean? Does that mean I have to look at the article online rather than the magazine? Probably. Crap. All right. Well, anyway, we have another research study on that, and I don't see it in here. Nope. Oh, here you go. The utilization of a mirror during pelvic examinations, does it improve the patient experience? Like if there were a mirror that you could see what they were doing down there, would that make you feel better about it? I'm not lying. There it is. Utilization of a mirror during pelvic exams. That's pretty entertaining. It's all funny. Some of it's quite funny because sometimes they study things which are just like logical. Like, yeah, don't you think people should know what their body looks like? And here's another one. We don't need to talk about that. Right. All right. Well, anyway, screw that. All right. Give me some hard questions. I had a lot of sleep issues for hours last night. Lots of getting washed done. Else kept across my desk. My iPad this morning. It's kind of an interesting article. Was this it? Nope, that's not it. Well, I will go over these at a research-centric meeting. All right. Chris says, on my ultrasound, they showed a post-residue of 168. Woo, girl. Is the treatment for this self-catheterization, as this is making me anxious? Girl, you are not emptying your bladder well. You know, if you had 168, your bladder is not emptying well at all. Were they able to give you a reason why? Are your muscles tight? Do you have a prolapse? You got to ask what the potential cause is. And yes, they can, listen, do not be afraid of learning how to self-catheterize, especially if you're retaining fluid like that. It's like literally the best skill you can have. Because if you ever get to a point where you just can't empty your bladder and you're in pain, you can use a catheter, and it takes seconds to do. I mean, it's so easy to do. No worries at all. It's a great skill to have. And the nurse will teach you how to do it. Piece of cake. And Anne correctly says B6. Soledad says, Bleach Shield, can platelet-rich plasma be useful for IC? And the answer is yes. And we did an article on that in our magazine last year. And here we have a study. We have studies from 2019 and 2020 that platelet-rich plasma is rich in many growth factors that, again, basically help the bladder. What's this latest study? This is published in nature.com. Repeated intravesical injections of platelet-rich plasma has been shown to improve symptoms of patients in IC. However, there is a paucity of objective evidence about the effectiveness of the therapy. In this study, we investigated the changes in urinary markers after platelet-rich plasma treatment. 40 patients with IC who were refractory to conventional therapy received 4 treatments at monthly interviews. The urine levels of 13 assessed before and after therapy. And the pain and symptoms significantly decreased after post-treatment. The success rates at 1 month and at 3 months, at 1 month and 3 months after the 4th injection were 70% and 76%. The pain scale, frequency, nocturia showed a significant decrease. Urinary levels of nerve growth factor decreased significantly. Ooh, that's quite good. In this study, repeated intravesical PRP injections provided significant symptom improvement in IC patients. There you go. So I think that sounds like a viable option. Yeah, the challenge with experimental therapies like that is you're really going to only get them at research centers. You're not going to be able to get these at, a local urologist. They're simply not going to know. They're not going to know about it. They're not going to have the equipment. They're not going to have the money to buy the product and participate in the research, et cetera, et cetera. Annie, thank you so much, Annie. Annie sent 310 stars. Thank you. Chris says they are now sending you for a cystoscope. You have a narrow urethra. Okay, so Chris, I was diagnosed with a narrow urethral stricture back in 7th grade, years ago, decades ago. And back then, their answer to that was what we call a urethral dilation. And that's where they physically stretch the urethra with a metal sound, and they start with small ones and they go to bigger and bigger. Or, there are couple of different ways to do that. But what they never did is they never said, well, gee, why is the urethra narrow in the first place? And for many people, the reason why the urethra is narrow because you have tight levator ani muscles. And let's look at this for a moment. on our handy dandy model here. So like, look, here's your pelvis, right? Hello, pelvis. This part is bugging me right now because I have this disc is compressed and this disc is compressed for me. I'm not happy about that. That's elder care, trying to lift people when you shouldn't. The lowest level of the pelvic floor are these levator muscles, right? Which keep falling off. All right, so look. The reason why the levators are important is that these are the only major muscle group in the human body of skeletal muscle that affect 3 critical body functions. You will notice that there are 3 holes in a woman's levator, 2 holes in a man. We have a hole for a rectum, we have a hole for a vagina, and we have a hole for a urethra. But if your levators are tight, what does that do? Well, you can see that the levator basically goes around the urethra. And so if this muscle is tight, it's going to be hard to pee. You're going to feel like you're peeing through a needle. If this muscle is tight, it's going to be hard to have sex. I was working with a young woman last week who as we were talking about her IC, I said, is sex painful? She said, yes. I said, how long has it been painful? She said, my entire life. I said, okay, have you always dreaded going to the gynecologist because you knew when they were going to put a speculum in, it would hurt? She goes, oh my God, yes. I went, hon, you have vaginismus. You have chronically tight pelvic floor muscles that began in childhood. And it could have begun with a trauma, because hello, you can fall right on these muscles and there's nothing to protect them. If you jam your crotch on the bar of a bicycle, that would be one way to do these. Another thing that happens when these muscles are tight is it's hard to have a bowel movement. It's hard to let stuff out of your body and it's hard to bring stuff inside of your body. So, it's important that you ask before they go flailing away with metal sounds and doing urethral dilations, which some doctors call raping the urethra, to be quite honest. That happened at the American Urology Association conference during a pelvic IC class about 5 years ago, where a foreign doctor asked patients anymore who it was. It could have been Rob Mulder, or I don't remember who it was, but what they said, urethra anymore. Now we ask, why is the urethra narrow in the first place? So really the only place now for urethral dilation is if you're completely blocked. If you're so tight you can't let any urine out, that is an absolute medical emergency. And yes, they would definitely go in there and try to open it to release some urine so that, But anyway, urethral dilations are very controversial now. And I had about 100 of them as a kid, and they're not fun. Laura says, I recently learned that I'm allergic to hormones, estrogen, estradiol, testosterone, and these were the only ones tested. I'm now off postmenopausal hormonal supplements for about a month and several months after estriol cream. And you are better, that your bladder pain, sensitivity, incontinence are all so much better. Peora has helped as well, and a complete elimination diet of the many trigger foods. Yeah, it's very interesting. We all have different sensitivities, and we all have to understand that hormone products, have a lot of other ingredients in it, preservatives, fillers. They might not be, it's not like they harvest these hormones from humans and sell them to other humans. These are usually from an animal model, or they're made in a lab. They're chemically made in a lab. And so I think it makes sense that some patients can have sensitivity to different hormone products. I'm glad that the Pure is helping. And I think ultimately in the end, Laura, it's still about maintaining your skin quality. And so just understand that your skin is in all likelihood going to get drier and drier and drier. So as that article that I was reading a little bit earlier, doing something that has an oil base that will help maintain some of that skin moisture is going to be fairly important. peanut oil, olive oil. I think coconut oil is the bomb because coconut oil has the natural antibiotic effect anyway. Jennifer from Wisconsin. How are you, Jennifer? Thank you, Rhonda. Thank you for your stars. So Chris said right here, sorry, they didn't last very long. Mine didn't last very long either. Well, undoubtedly, it was my muscles that were the problem. I have no doubt about that. Brenna says, I've taken 3 different anticholinergics with no effect, also cyclobenzaprine muscle relaxer with no spasms. How do I get the spasms to stop? They are excruciating. So Brenna, we have to know where the spasms are. You've got 2 different types of muscles in your pelvis. You've got the smooth muscle of your bladder compared with the skeletal muscle of your pelvic floor. So because they're different types of muscle, they require different therapies. So the cyclobenzaprine, which is what I use, is a skeletal muscle relaxant. So if the skeletal muscle relaxant didn't stop the spasm, then that makes me think that you're having smooth muscle spasms. Do they happen all the time? Are they 24 hours a day, or do they just come and go? An example of a smooth muscle relaxant is going to be ditropan ditrol. So if it's your bladder wall, spasms are kind of the penultimate way of your bladder screaming at you. And for me, when I had bladder spasms, I've only had them once, and it was with an infection that I had for a couple months that we thought was a flare. And then my urethra got more and more tender. And then as the last couple of drops of urine were coming out of my urethra, I would just bend over the toilet. I mean, it was like oh my God, and you're just like laying here going, you're just sitting here on the toilet going, please stop, please stop, please stop. And it takes minutes. It takes minutes for that violent bladder spasm to go away. 5 or 10 minutes before that violent bladder spasm to go away. 5 or 10 minutes before you can actually get off the toilet. Sometimes I was laying on the floor of the bathroom with a bladder wall spasm. Spasms is kind of the last ditch effort of your bladder to say, help me, help me, help me. It is extremely irritated. So now we have to figure out why. That you are in excruciating spasms is important. I would have, number one, a next generation urine test. Let's make sure they haven't missed something. Could you have a chronic fungal infection? Could you have a chronic, more rare bladder infection that typical urine cultures will not identify? That would be like the very first thing I would do if I were in your shoes, Brenna. I would want a pelvic floor assessment. I would want to know what's going on with your muscles. And we ultimately have to differentiate between, is it smooth muscle or skeletal muscle, to figure out how best to treat it. Loris, my doctor thinks I'm also allergic to my own hormones. Interesting. And that is the cause of my well, you can't use the word I see there. That's misleading. That your doctor thinks you're allergic to your own hormones, and that is the cause for your bladder wall irritation. Don't say I see there. Don't you have to be a little bit more specific here. Marie sent 100 stars. Thank you, Marie. Anne says Facebook is ridiculously, it's freezing all the time. Cindy said, I had dilations and the entrance to my bladder cut off in the 80s. Oh my God, Cindy, girl. All right. All right. So I don't know what to do with you guys. This sucks. So for Facebook, you can all come on over to YouTube. If you're freezing bad, just go to youtube.com/IC and Jill. The other thing I can do is I can restart the stream. Here, hold on a sec. If you'll work with me here, I can, okay, so hold on a sec. So let me turn that Wi-Fi off. And we are hardwired into AT&T. Let's make sure the hardwire is working. The hardwire is working. I tell you what, Facebook, let's do an experiment. Brandon, it's a next generation urine test. Okay, so this is what I want to do. I'm going to split Facebook off of this computer and I'm going to put it on this computer. And I'm going to run you guys on AT&T. And let's see if you freeze on AT&T. Okay? So we got 32 people watching right now on Facebook. You guys, let me end this, but I'm going to start it right back up again on my other computer. Okay? And let's just see. Hold on. Let's just see if that makes a difference. Because this is the future, man. That's got to work. I got to figure this out. All right. So hold on a sec. Let me just stage it. Oh God. See, and you're going to see me from the side. And my profile is terrible compared to looking at me from front. All right. Oh, I just gotta move it. Okay. Well, apparently I accidentally ended that. So, okay. So hold on. YouTube, you guys, hold on a sec. Okay, join us for part 2 of our live meeting today. Hopefully this will stop the, well, let's see. Questions that I see. Okay, and so, wait. I need a microphone for this other computer. All right, let's see here. Gonna wrap this around this other microphone. And hold on, let me check this. Okay, what? Camera issue. What's a camera issue? What? Come on, people waiting for live video. What the hell's wrong with the camera? Oh, no. Oh my God. All right, YouTube, you all can see me. You want to see me have a little meltdown? What is wrong? Because there's a camera issue. Now, come on. I use this. Select media source. Ah, crap. Let me just reload it. Now I got to restart that computer. All right. YouTube is much better. No freezing. Change to YouTube. You guys, thank you. Bridget says, I'm using Estroderm MX50 patches and have been for years. I'm on a very strict diet, not even tea, and my bladder is in almost a constant flare, taking low-dose tramadol, which gives some relief. So, Bridget, listen, if you're not responding to therapy, what the AUA says is take a step back and let's revisit the diagnosis. Let's see if we missed something. I mean, pelvic floor flare? That's something we would want to know. It could be both, or it could be estrogen atrophy. Do you have uncontrolled estrogen atrophy that is here? Oh my God, look at all this unsaved work. Okay, hold on. As you age, your skin gets drier and drier and drier, right? Here, hold on. Tips. Okay, that is saved. This is my production. I have a production computer and I have a streaming computer. All right. And I think, all right, hold on, almost there. So I would really, Bridget, I would want to know, number one, what's the health of your pelvic floor? Number two, what's the health of your skin and estrogen atrophy? And number three, I would also want to know, is there any chance that you have Hundreds lesions? Do we have some untreated Hundreds lesions that are persisting in your bladder, causing a lot of problems? I mean, that's also possible too. You'd be amazed by the number of people who have Hundreds lesions. They were told they have Hundreds lesions, but they've never been treated correctly, which is really sad because Hundreds lesions hurt like hell until you treat them. Once they're treated, the pain usually goes away or improves 80 to 90%. But there's nothing more tragic than somebody who has been told they have lesions and the lesions are not treated. It's infuriating for them. It's infuriating for me because in some cases, patients are suffering for years, completely unnecessary. Liz says, I've had estrogen positive breast cancer twice. Is there something else that I can use? Well, first of all, I want you to Google topical estrogen safety. Just to look at that research, because there are some research studies out there that are now saying it's safe to use even if you've had an estrogen dependent cancer. But obviously that's shaky. Number one, patients are terrified of getting cancer again. I certainly am terrified of getting cancer after going through my whole uterine thing. But when you actually look at the studies are pretty encouraging that topical estrogen put on the skin is pretty safe overall, and you don't see a lot of systemic absorption. But I certainly understand any concerns you would have, because I would have those same concerns. All right, I got this computer rebooted. Of course, this is my oldest computer. Oh, wait, no, wait. I'm not going to do it on the pre-leaf page. I'm going to do it on the IC network page. Jill. Holy crap, is that quality bad? Wow. Look at that. They told me this should not happen. All right, so hold on. I'm just starting up a stream. I'm going to try to. Oh, good. It's working. Okay. And I've got the external microphone. And all right. Live IC and pelvic pain support group part 2. Okay. All right. Okay. Facebook is starting up again. Let's just see what happens. Thank you, you guys. Okay, well, we will see. Elizabeth says, yes, I need to address the hunters. So remember, hunters lesion therapy, hunters require hunters specific treatment, lesion specific therapies. Hunters lesions don't respond to oral medications other than perhaps pain medication. The way we treat a Hunter's lesion is by injecting it with a steroid. If we inject it with a steroid into the center of a lesion, that helps reduce a lot of the inflammation. Or they can cauterize it or laser it, or they can use hyperbaric oxygen therapy. Hyperbaric oxygen therapy, that you're basically in an oxygen chamber, which pushes oxygen into your body, into your bloodstream, that really supports healing. So that would be something. Or we have Lyris, which is the first treatment in history to actually heal Hunter's lesions, but it's not available yet. All right, Facebook, we are back. And now you get to see one of my work boards over there. So they have a different background than you guys because they're looking at me from this angle. All right, so Facebook. Hello again, Carolyn. You guys tell me what the stream quality is like and if you freeze, because you're now on a completely different internet service, okay? All right, there we go. All right, so Facebook, y'all let me know. So normally we would be going into our Zoom meeting right now, and so I want to invite anybody who wants to get a personal coaching session from me right now. You can do that by coming into Zoom. That's going to be, everybody's going to hear it. So Facebook, I'm looking at you over here on my other computer. YouTube, I'm looking at you here. I'm going to go ahead and start Zoom up. I will post the invites on both computers. And this is your chance to come in and talk to me directly. Everybody else will be able to hear you, but they will not be able to see you. Hello, Donna. Donna, you're missing lots of internet drama today. Okay, so hold on. So the way to get into the Zoom meeting is you go on over to our website, icnetwork.org, and that's exactly what I'm doing right now. And on our page, you go to the support pull-down menu and it says streamed support group meeting. And there is my face with curls. Rarely see my hair curled. And you will see a link to the Zoom meeting right there. And that's how I'm launching it right now. So let me just go ahead and launch that meeting. Alrighty then. Okay, so the meeting is now launched. And let me get the invitation. I'm going to copy the invite link, and there we go. I am going to put it on YouTube. There you go. And here, for those of you, okay, Kim, it's still freezing. Listen, if it's still freezing and you're on a completely separate hardwired internet, it's not us, it's Facebook. Because YouTube is not freezing. I don't know what to tell you. Facebook's having a really bad day right now. No sound? You have no sound? Kim says, yeah, it has to be Facebook. Danielle says, is COVID vaccine causing flares? For some people, it's causing little flares, but compared to the terrible damage that can happen with an active COVID infection, the risk of the vaccine is tiny compared to the risk of the getting an actual COVID infection. All right. So Facebook, I hate to say it, I think you're a lost cause today. I don't know what to do. I don't know what to do for you. The stream quality is poor. So let me just give you this, and you can come on over to Facebook or you can go into Zoom, okay? So let me just give you the link. Baffling. baffling. Whoops, that's not right. Give me a quick second and I will give you guys the link. All right. So, okay. So Daniela now says there's no freezing on Facebook. All right. Now Facebook says you're fine. Now, oh, Loretta said, oh my God. Okay. Y'all, I just don't know what to tell you. So we're just going to go into Zoom. Let's just go into Zoom. All right. So Facebook, look, here's a link to Zoom. Come on over to Zoom. All right, YouTube, you guys have the link to Zoom. If y'all want to come in and ask some questions, click on the Zoom link and let's do that. Because some days it's meant to be and some days it clearly isn't. Hello, Becky. How are you today?
Hi, I'm okay. How are you, Penny? Be a good girl. Sorry, my dog.
Well, never thought I would have to be an expert in technology in addition to IC and Bladder, but there you go, doing the best I can. So
That's
what can I help you with today?
Oh, okay. So I wasn't sure, like, do I want to talk about this, in front of everybody or not?
Well, nobody can see you but Laura and I, but they can hear you. So,
right.
And I haven't said your last name, so.
So I think it makes sense to share it because maybe other people are going through the same thing.
Okay.
So I am doing okay right now. Like I have been flaring, but it's like I know why and I know what I need to do to treat myself, and I just sort of haven't been doing it.
Okay.
I've been going through a rough time. I lost my grandmother who I was really close with, and just everything with COVID, and I'm slowly going back to work. So I got behind on my physical therapy, my diet, and all that stuff. And then I'm also using hormone cream. And I have estrogen and I have testosterone.
Okay.
I went back to physical therapy. I've been for one session so far and I'm doing somewhat better.
Okay.
But, having a problem with sex, and that's the reason that I use the hormone cream, like partially, that's why I have the addition of the testosterone. And it's like the clitoris is not working,
Okay.
Like it just doesn't function like it's supposed to, where everything else is like the lubrication and it's not as painful as it used to be. And so I don't know, my doctor is really great. And she gave me this new thing that's called Scream Cream. And she said it's new within the last year or so. And it has basically like a low dose of Viagra in it that you use like right before sex. It doesn't work. So my physical therapist is telling me that hopefully it will, the physical therapy.
Well, yeah.
Will help.
Well, I mean, if you've got pelvic floor dysfunction, you're not going to have a normal sex life.
Yeah.
Because, I mean, the nerves that support having an orgasm travel through the pelvic floor muscles to get there. And if the nerves are messed up, you're going to be messed up. That's why one of the symptoms of pudendal neuralgia is persistent genital arousal disorder, where you feel like you're slightly aroused, but it's painful and it's really icky and awful. That is, have you had that before?
Not exactly, but I mean, I know what you're talking about. And when I do get aroused, it is painful, like it pain comes along with arousal. But right now, yeah, it's just like certain parts are not functioning at all.
Well, so to me, you can't, everything depends upon the health of your pelvic floor down there, especially your levator muscles. And you saw this, you see this diagram here, right? So look, you can see that you've got muscles all the way up at the top by your clitoris. And so
Yeah,
if
and it was painful for me too. Like,
right. And so I think that you have to focus on it. I mean, you've only done one pelvic floor physical therapy appointment so far?
yeah, I mean, I've done it before, on and off for like 7 years, but they always discharge me when I'm doing better. And then I have to, bring myself back in a few months. So that's
Okay.
where,
Right. Okay. So that opens up something that's far more interesting, and that is, why does it come back?
mhm.
Why do your muscles go back to a tension pattern? Like my muscles on my left side go back to a tension pattern. Why does that happen? That happens because usually of a bony structure abnormality, a bad hip, a bad SI joint. For me, it's my SI joint. It's the joint right here. Whoops,
Okay.
right here, right? So this joint is normally very stable. It's not supposed to move. Mine moves. And because mine moves, the muscle, the piriformis muscle, is trying to hold it together, and it's working very, very hard. So for me, I always have muscle tension right here, and it's manifested a lot right here, right on the sit bone, right? That one piece of bone that you feel right in your butt cheek. It could be a bad knee. Are you limping? Are you walking weird? It could
Yeah.
be a bad foot. But it's going to be very difficult to have a normal sex life if you don't have good blood supply and you have nerves that are compressed. And so I'm not surprised that sex is painful for you right now. I think what would be an interesting experiment would be, would some women use a muscle relaxant before sex, like a
Mhm.
vaginal Valium suppository? So that would be interesting. If
Yeah, I could try that again.
yeah,
Um,
Well,
I mean, I've tried that before. I feel like it wasn't right for me, but I could try it again. Um,
or baclofen,
or
baclofen,
um,
something like that. Either it would be interesting to see if the muscle relaxant would help before, and it would certainly be interesting to see if it would help immediately afterwards. But sex should not be painful.
right.
And so it's important that you ask your doctor why, because sometimes you can get things stuck under your
Mhm.
clitoral hood. That's happened to me twice. And it's just weird that you have something stuck under there that is a constant source of irritation until you can get it out.
Huh. That's interesting. I've never thought about that. But you've inspired me to like go back to the doctor and yeah, I like want to find out why, because last time I saw her was maybe a year and a half ago or a little bit more than that. And I said, I'm fine. Like, I know what I need to do, and I do the physical therapy, and I do the diet, and I do the hormones, and that works for me. But, like you're saying, it's like, why do I have to keep going back to physical therapy? So this time I came back, and she did she sent me for a pelvic ultrasound and the transvaginal ultrasound, which they had a student do, and it made me flare. So that wasn't my favorite experience. But
Well, and the fact that the transvaginal ultrasound was irritating tells me your muscles are tight,
yeah,
right?
yeah.
It,
Yeah. So, but we didn't find anything there. So yeah, it's still like a mystery, right?
okay, so this book, Facing Pelvic Pain, has chapter 18 is dedicated to sex and intimacy.
Okay.
And the subhead, okay. So the subheaders are: how is pain during sex different for men and women? Is sexual pain different based on my sexual orientation? How can I decrease pain during sex acts physically and mentally? What alternative strategies can I use to have an active sex life despite my pain? Does persistent pain mean an end to intimacy? And no, and I have a hysterical story to share with you guys about that. How can pelvic pain affect sexual function? And there you go. And so this is free on Kindle Unlimited. So just go get it on Kindle Unlimited and read this chapter and see if there's something on this chapter that would be useful.
Will do.
Let me just see here real quick. I'm just curious. Okay, how can I decrease pain? So treatments might consist of medications, pelvic floor physical therapy, sex therapy, and or a combination of all three. And by the way, we do have a sex therapist that we work with that works with couples. Her name is Heather Howard. She's wonderful. No matter what type of sex you're having or want to have, communication is key. Oh, anyway, let's see if there's anything else here. Well, I'll tell you what, I will let you read this. And then also the other book is here, hold on a sec. So we have this, stable of books that we refer to. So on this book, Secret Suffering is all about how women's sexual and pelvic pain. Okay. And there's a wonderful, there's
writing it down.
Yeah, there's like 200 tips and they talk about all sorts of things. So there you go. So this would be good. This whole packet of called Secret Suffering. You should Amazon. And that's by Billheimer, Susan Billheimer. YouTube, there you go. Secret Suffering. Okay. And let's just see. I don't remember if this book had a section. It says the book has a section on PGAD. Another book that's free on Kindle Unlimited is Breaking Through Chronic Pelvic Pain. Go to the section on PGAD, and you might get something in there that might be helpful. Okay. Again, Kindle Unlimited. Let me just see if this book has page 129. Okay, so this book is Heal Pelvic Pain by Amy Stein.
Writing it down.
Yeah, Heal Pelvic, and this is a fairly small section, but let me just read this, okay? Because I think this is interesting. We don't need to go about the importance of sex. Obviously, it gives us, it builds our relationships, et cetera, et cetera. Sexual activity increases blood flow, which in turn equips the body to fight or fight off harmful bacterial infections and viruses, yada, yada, yada. Sex helps us keep our muscles strong. Orgasms, after all, are muscle contractions. So the more intense the orgasm, the greater the strengthening of the muscles. And vice versa, of course, the stronger your pelvic floor muscles, the more intense your orgasm. Strengthened muscles, in turn, mean a lowered risk of incontinence. Orgasm relaxes the body, and the stronger and less tense the muscles are at a core, the less hard our bodies have to work. Okay.
So I just got married in January. So, my husband is really fantastic and understanding, but I want to, I just want to see this improve.
Well, and you should invest in a Tenga for moments when we can talk about that offline. So just as important as the physiological benefits are the psychological and emotional payoffs of a healthy, intimate life. Yada, 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 yada. I don't need to do that. Okay. In so many ways, therefore, sex is very, very good for us. And that means better sex is even better for us. And that's where the pelvic floor comes in. It is, after all, the core of the body and such, the seat of sex. The nerve endings of the pelvic floor are what respond to sexual stimulation. Its tissues and blood flow are where arousal takes place. Its muscles are literally the vehicles of sexual pleasure. In men, sexual arousal increases the sensitivity of the nerves, et cetera, et cetera. So a healthy pelvic floor, one that is well-toned, yada, yada, is all the ingredients to ensure a healthy sex life. So I think ultimately in the end, we have to work on your pelvic floor.
Yeah.
Okay. And then in the meantime, now listen, I'm going to tell you all a funny story. I'm going to tell you a hysterical story. Okay. So I started my support group here in Northern California in 1993. And in the first 6 months, my co-leader found a sex therapist at UC San Francisco who is a professor of medicine and doctor, and invited him to come and talk about sex in the IC patient community. And we're like, great. He said yes. So we were excited. Nobody had met him before. In walked Santa Claus. I am not lying. The guy looked like Santa Claus. He had a long white beard. He had long hair, a big belly, and suspenders. And we were all like, Santa Claus?
Not who you were expecting.
Oh, it was so funny. And of course, literally, like the very first thing he said to us is never, ever, ever ask a doctor for sex advice. And we're like, why? He goes, because they're just as dysfunctional as anybody else. Think about their schedules. They're on for 48 hours off. If you think doctors are have normal sex lives, you are wrong. And he was hysterical, right? We were rolling laughing. It was so good. And he explained also that as our relationships lengthen, our expectations change. Just like aging changes. When you're young, sex is very short, and it's all about getting there and being done. And there's not a lot of cuddling and stroking when you're, 18 years old or 22 years old or whatever. It's about getting to the end and being done. I'm trying to be right because I know we're on Facebook and, so I'm trying to be careful with what I'm saying here. That's very different from somebody who's in their 50s who maybe can't get it done right away. And for them, sex, they start to appreciate more the intimacy. So what we from the physical act to the comfort, and it just balances over time until by the time you're like in your 90s and the physical act is impossible, but you can absolutely hug and love each other. And in that way, right? They do that. They sleep in the same, but obviously sex is not possible. So anyway, this guy was great. And he said, now I got to tell you about one of my clients. And we're like, okay. He goes, frankly, I envy the guy. This couple has the most intimate, satisfying relationship I have ever seen in my entire life. I don't even know why they come see me. I envy their intimacy. And we're like, we're like, okay. He goes, but you have to understand there was a problem. And we're like, okay, what? He goes, well, he was in the war. We're like, okay. He goes, no, he was hurt in the war. We're like, oh, he goes like, no, you don't understand. He lost his penis.
Wow.
That in an IED, gone. So the question he posed to us is, how can a man without a penis have a sex life that every other man envies? And the answer was not intercourse, but outer course. And I can't go into detail on that, but I can do that offline with you. I talk about it on our website. It is less about things inside of your body and more about pleasuring from the outside. So anyway, and I want to say more, and I just don't know how far I can go with a live meeting. So I'm going to stop there. But anybody can call me, and I will talk to you about it. And I can even write an article about it. So anyway, so he basically said the secret to sex is to get your partner to that moment right before orgasm and keep them there. However you need to do that, with touching, stroking, whatever. Normally that moment lasts 30 seconds and then you're done. But what if it lasted for an hour? How would you feel? Well, so he sent everybody home with a lesson on outer course. In teenage, late teens, early 20s, and I had 75, 80-year-olds in my meeting, and they all walked out of the meeting with their heads together, like they're like, ooh, maybe we should do this, right? They came back a month later, and they were glowing. They were glowing because they always thought that sex was about just kind of the act. They didn't understand the pleasure side. And couple that was in the best shape were the 70-year-olds. And they were blushing. They were blushing. And they said, Jill, if anybody just taught us that in our 20s, our sex life would have been completely different. You know, that it's not necessarily about just the act itself, it's about getting there. And I can't say more, and I'm sorry, I don't know how far I can go. But if you want to talk about that, I would be happy to talk to you more about that. Does that kind of make sense? Google outer course. You guys Google outer course or tantric sex. There you go.
Thank you. And I mean, I thought it was useful to bring it up, and I don't mean to put you on the spot either, but I think, you know, other people might be going through something similar and think that they, you know, are the only one. So
I have this conversation at least once a week with a patient. This exact conversation. So happy to do it, hon. All right. So
thank you.
So your homework.
And thank you for everything that you do. I appreciate you very much.
You're very welcome. So your homework is get back into that physical therapy, and now we got to ask the question: why are your muscles chronically tight? Okay.
Yes.
All right.
Thank you.
Okay. You're very welcome. All right. And hold on Facebook. Hello, Debbie from Gulf Shores. Okay. So you guys, Facebook, how is it doing? Are you freezing at all? Are you freezing on AT&T versus Comcast? All right. We're going to go next to Becky. Or did I just do Becky?
Yeah, that's still
I
me.
did. I'm sorry. You're right next to, or we're going to, no, wait. Okay, I just lost her. Where did we go? Who is the second person that was in? It was Laura, and then Laura disconnected, and then iPhone came. Okay, so I'm going to go to Laura next. I'm sorry, Becky.
Yeah. Okay.
How are you, Laura?
Oh, I'm okay. I'm much better than I think the last time we spoke because of the, you know, going off the pregnenolone and the estrogen.
Right.
And so I'm still going to be exploring. You know, I need to get back with another urologist specializing in pelvic pain that I'm happy with. The last two.
Okay.
You know, it's been tough. But I do need help with, you know, just suggestions of how to heal the bladder lining, because I mean, I was essentially in remission eating Indian food this past year, could start eating, you know, just all sorts of acidic foods. I've always been hyper sensitive to anything acidic, and it's always brought on the bladder pain. And so I really want to be able to heal my bladder. And I feel like it's just going very slowly. I've been taking the Peora, and I tried the bladder filter, but I believe the conjointion really makes my reflux. There are other options. So I've been taking the Desert Harvest Aloe because I know it, you know, coats the lining of, it coats the bladder. But as far as building up that healthy tissue, maybe just over time.
Well, I mean, you, honey, first of all, I love talking with the redheads, and you're right. I mean, like twins, pretty much. Okay, so aging happens. We're never going to get back to a 20-year-old bladder. Now we're dealing with the bladder of whatever age. I can't tell what age you are. So
we're the same age.
Okay,
just
there we go.
A year, I think. Yeah.
Right. Okay. So when we use compounded estrogen, we're giving that tissue what it needs to produce more mucus. And so but even that is never going to get us back to a 20-year-old bladder. We now have a 60-year-old bladder. So it's not a action. It's about what can we do that will help the bladder protect itself more. And that's going to be more, because there's not necessarily a disease process happening for us. We have estrogen atrophy, genital urinary syndrome of menopause. Okay. Is there somebody there?
Not anymore, Bob.
Oh, it's okay. It's okay. I always love to see other people and wave. So, my brain's going in two different directions right now. So concept number one is a barrier. So the best barrier that we have, according to the research, is chondroitin. We had a study presented last year at the European Society for the Study of IC, or Study of Bladder Pain, that showed that chondroitin was the most successful at restoring the superficial integrity of the bladder wall. So to me, even though that was for a bladder installation and not an oral medication, that's all we got. That's what we've got. So of all the ingredients, to me, the most important ingredient is going to be chondroitin. The challenge here is that you and I are sensitive because we're redheads too. And we, it is what it is. So when you were taking bladder, or how much were you taking? Were you doing 4 a day or 2 a day or 1 a day?
Just started with 1, and that gave me some stomach cramping, but I just said, oh, just tough it out. I got up to 2. The stomach cramping, was constant.
Okay.
I mean, it was a dull stomach pain, 24 hours. But then after a few days of taking 2, the reflux was
too much.
And I went back to 1, reflux still bad. So
okay. Well, I mean, it happens. We all have our issues. We all have our own sensitivities. So the question is, what ingredient in bladder builder would be the most inclined to do that? And it's usually the probiotics, because there are some strains of bacteria that actually provoke a histamine reaction throughout the body. And that's what, I was always wondering.
Oh,
yeah.
I'm sorry, Jill. I'm sorry to interrupt. I was taking bladder rest. I'm so sorry. Yeah, because I already take my own probiotic.
Okay, so you were taking
rest.
So you were taking. Yeah. Okay, well then it's just not for you.
Yeah.
So bladder rest uses avocado oil rather than olive oil. Do you have an issue with avocados?
Nope.
All right, and it's just not for you, hun. You're just sensitive. I will tell you that I never got past 1 capsule of any chondroitin a day. Mm-hmm. And even then, if I took 1, my stomach kind of went, woo, what you just put in me? And then that'd be gone in 5 minutes. But not everybody has the same level of tolerances. I think you and I are in the same boat as redheads. So the Peora, the nice thing about the Peora is that it's nerve calming. You and I have sensitive nerves, and it has very, very few side effects, if any. I guess you could consider a bladder installation if you wanted to. I mean, it's a little bit traumatic, but it might be interesting to see how you did with a heparin lidocaine installation.
Yeah, that's been a long time since I've had those. And at first they seemed to help, and then later it just seemed to make me flare. So I didn't go back to those.
And of course,
I'm taking 3 Peora a day.
Okay, and of course, last but not least, understand that when you are older and you have drier skin, you're more prone to infection. So I think doing a next generation test to see if you might have a chronic fungal infection would be interesting.
Yeah, I've never had the next gen test, so I'll do that as soon as I go back to my doctor.
Yeah, I mean, because if you're getting worse rather than better, there's an active process happening somewhere, and we have to try to figure it out. So that chronic fungal infection or even a chronic bacterial infection is absolutely possible. Okay.
And then, like for vaginal moisture, if I'm not using the, this is my last question, if I'm not using the estrogen, is there something that is helpful?
Well, normally it's going to be an oil. It's an oil-based thing. So some people, have used peanut oil. Some people have used olive oil. Some people have used coconut oil. Coconut oil has a little bit more appeal only because it has a bit of an antibacterial effect. That said, any of those oils that if you're using them internally, you've got to get a really, really high grade oil like the coconut. I've never used coconut oil internally. I've only used it externally. What I have used internally is KY, and we have Luvina. Where is it?
Oh, yeah.
So This line of products, the Luvina line of products, they have Luvina Vaginal. But they also have what was it? In the Luvina Vaginal Moisturizer, there were a few ingredients that had the potential of maybe being a little bit irritating.
Oh, okay.
So, and then, what did this book say? What did this book say about the oils? It was, they were talking peanut oil and olive oil and KY and they had several. So this is free on Kindle Unlimited. Grab this and take a look at the Bible. Dr. Jen Gunter. This book is the bomb. It is so good. And she has a new one that's coming out, I think in June, called the Menopause Manifesto. I can't wait to get that. And let's just, out of curiosity, see what she says in here. She's a pelvic pain specialist out here in California. And she's very active on Twitter. Lubes. Okay, let's see here. Lubricants. All right. 172. Hold on a sec. Let's see what she says. Vaginal moisturizers. All right. Vaginal moisturizers are supposed to rehydrate vaginal tissues and replace lubrication. They are used regularly, not just during sex. Studies tell us that vaginal moisturizer improves symptoms, especially the sensation of dryness. Moisturizers are most effective when there is one main bothersome symptom. They are unlikely to treat odor as they do not replace lactobacilli. Vaginal moisturizers have a temporary effect on vaginal pH, meaning the physical presence of the product lowers the pH, but does not cause the lactobacilli to grow, as it does not increase sugar in the area. Moisturizers can be water-based, silicone, oil, or hyaluronic acid-based, or a combination. Hyaluronic acid is a large molecule that is found in and around skin cells. Vaginal moisturizers are formulated so that the active ingredients adhere to the vaginal mucosa, so they stay in place for several days. Most of them are meant to be inserted vaginally every 2 to 3 days. They are often the placebo arm in studies of vaginal hormones, and sometimes they perform as well or almost as well as low-dose estrogen. When stopped, the symptoms will return. All right, let's see. So what does she say here? Lubricants are discussed in depth on chapter 9. So hold on a sec. Let's just see what she, I mean, this is a fantastic book. I love it. Chapter. All right. The chapter's called The Lowdown on Lube.
Oh,
That's funny. Earthy and gritty. All right. Choices. Oh man, she goes all through this. Okay, you know what? I'll just leave it at that. Guys,
thank
the
you.
Vagina Bible.
Got it.
Fabulous book. And if you're over the age of 30, get ready for the Menopause Manifesto. I can't wait to read it.
I'll be looking forward to it. Thank you, Jill.
Because our mamas didn't teach us about this stuff.
No.
All right, hon. Keep in touch.
Okay, thanks.
All righty. Let us go to, okay, so Charlita, Shell, and Sherry. So let's go to Charlita. Hello, Charlita. Can you unmute yourself? You have to unmute yourself so you can talk.
I think I did it then.
Yeah. How are you, hun? How are you today? How is life?
Life is busy, hectic.
Yes.
I have a 6-year-old and an 82-year-old in the house.
Uh-huh.
with having mild flares. I think they're stressed. Don't laugh. Stop on me.
No, I got a 98 and a 92-year-old in my house, girl. I'm laughing in shared commiseration, girl. I get it totally. I was up
I know you do.
I was up for hours last night with the after effects of Dulcolax.
Oh, Lord.
It wasn't pretty.
Yeah. No, it's never pretty.
No.
My main my main problem right now is the Elmeron effect on my eyes.
Okay. Okay.
Yeah, my right eye. They told me there's a lot of damage in it.
Oh,
And you know,
no.
I'm hearing impaired. You know, I'm deaf.
Okay.
So the combination is, I need lots of prayer.
I'm sure.
Stress right now.
I'm so sorry, hon. I'm giving you, this is the new online hug. So I'm
Thank
giving you a big giant hug right now. I'm so sorry that you are going through that. Now, we have a Zoom meeting on Wednesday
Mm-hmm.
with
I
the
plan on attending.
good.
Yeah.
And we do have our first study of a therapy which has helped.
Seriously?
We do. It came out last summer. And hold on a sec. If you go over to I have a website on this called pentosaneeyedisease.org.
Okay.
And that was the first website built on this. And I try to keep it updated. And so last June, a treatment with something called anti-VEGF therapy. So researchers in Canada shared a case study of a 59-year-old woman with non-leaking macular edema associated with pentosan polysulfate pigmentary maculopathy. She was treated successfully with intravitreal injections of a new medication called bevacizumab. Bevacizumab. This report is the first associated eye issues with these injections.
Okay, because I had seen some things about an injection that progressed the eye disease very quickly. And I didn't know if that was anything related to what you have been putting on. This is something I saw through one of the legal websites. So I really don't know that much about it. A woman they did eye injections and she went blind.
What?
Yes, she went blind. I didn't note it or anything, but I should have said, telling you what I saw. And I haven't had any luck with the attorneys that I've contacted today. That's why I'm going to do the 31st.
Well, you want to definitely reach out to Krista and Aaron. They're at Kruger Dickinson, and they're the ones who kind of led the way with the first. Then they'll be speaking. So Krista and Aaron would be, and Michelle would be, they would at least tell you straight. I like working with them very much. I think that they have their hearts in exactly the right place.
Well, for me, it's not so much monetary. It's the fact that I am deaf.
Yeah.
I have a 6-year-old. I have my mom.
Yeah.
And I'm it, I'm it.
Yeah.
So I can deal with being deaf. That's not a big deal. But losing my eyesight is a big deal for me.
Right.
And so far, it's only my right eye. And the left one is not showing it.
When did you go off the Elmeron?
Oh, a couple of days after you posted the article.
Good.
I said, I'm not taking this stuff.
Yeah.
So I stopped it almost immediately. And I had a new urologist whom I contacted, and he immediately contacted all of his patients who got him off of it.
Yeah.
Good guy.
Yeah.
Very good. Young, smart.
Yeah.
Does a great job.
Yeah. Well, okay. So why don't you come to the meeting on Wednesday and let's see what they have. I want you.
No wonder we're friends.
Well, no wonder we're friends. We have the exact same pair of glasses.
The exact one.
Isn't that funny?
One.
That's funny.
Yes, it is. You have always been so good to me. You've been such a good friend.
Well, I mean, guys, you have I've had to share was the Elmeron pigmentary maculopathy study. And I found it. I've told this before, but I think it bears worth repeating. I think it's important that we all understand the choices that everybody's making in this tragic situation.
Mm-hmm.
So here we have the doctors from the Emory Eye Institute who are referred a couple dozen IC patients who all have this weird eye thing. And they rule all the genetics out, they rule everything else out, and they finally realized what they had in common is they were all taking Elmeron. And so they published their first case series in the Journal of Ophthalmology, I think it was 3 years ago this spring.
Mm-hmm.
And urologists don't read the Journal of Ophthalmology. Urologists barely read the Journal of Urology. They're busy too. And so what they did is they wrote a letter to the editor to the Journal of Urology that was basically saying, found a new eye disease associated with the use of Elmeron.
Mm-hmm.
And when they sent that to the Journal of Urology, urologists were notified, and yet they didn't talk about it. They didn't talk. Nobody was really talking about it. And then it was over Labor Day. I was cruising the National Library of Medicine, and I found this reference to this little letter to the editor. And thank God I have a doctor who lets me use his $1,000 subscription to the Journal of Urology. I could go over there and I read it. And I was stunned. It was stunning that they had no way to notify urologists other than through this letter to the editor. Who reads letters to the editor? Specifically about IC. So then I went over and purchased their article, and which I think I have it right here. And I will tell you that I was sitting at this very desk and I just started bawling because hundreds of thousands of patients have used Elmeron. That was the guess. They thought it was hundreds of thousands of patients. And I gotta find it. I messed up my files. Anyway, so like I'm reading this going, what the hell? Oh my God, this is terrible. The pictures were stunning. And so I sent a letter to our board of directors, to my medical board, and I just said, hey man, let's credibility. Number one, do you know about this? Number two, let's credibility test this. Let's do a survey. And my survey now has over 2,000 patients in it. And 54% of IC patients who've used Elmeron report retinal disease. Mm-hmm. And the question then is, what about what's the duration of use? And the original hunch was that you had to use it for a long period of time. But our study showed that patients' eyes were changing in their first year.
Yeah, mine didn't.
Yeah.
Until later.
Yeah. So now we have patients who have legitimately they are now legally blind because of this change in their eyes. And so the lawsuits are growing, and they're filed in federal court. They've been filed in state courts. And I had to make the decision of, do I talk about this or not? And I just felt like you deserve to know. And, if I hid it, didn't talk about it for a year until we had more data, I think you would have come back yelling at me saying, why didn't you tell me a year ago when I could have stopped it a year? So
the very minute you put the stuff, I printed it out and took it to my doctor.
Yeah.
Immediately I took it. And they said, I don't know this woman. I said, you need to know this woman. you need to pay attention. If you're going to be a urologist, you need to know about this group. You need to know this woman. And she talked me off the ledge a couple of times. And he just kind of looked at me sort of shocked because he was just taken over the practice, so he didn't know much.
Yeah.
I gave it to him. I said, read it, research it, and I give him the credit. He did it. He did what I told him to do.
And he went, this is not good.
It scared him. It scared him because he said, I've got patients on it. And I said, I was on it because it worked for me.
I was told
the only things that really helped me.
I was told at last year's ophthalmology conference, they surveyed the room, and that every retinal specialist in the country said they were treating Elmeron patients.
Yeah.
That's secondhand. I mean, that's not firsthand. I wasn't there, but it's meaningful. So let's see what the attorneys have to say. And I do honestly believe that you're that. So the other critical question is did the company know? And that's where the Emory researchers did their due diligence, because they went back in that first article and they found the first major clinical trial with Elmeron that was done in 1996 that found eye disease. And they reported it. They reported it in the journal article, but I think the case is meaningful. So they knew in that study that eyes were changing, retinal hemorrhaging. They knew that was happening. And yet when you look at the patient education materials,
Mm-hmm.
and you look at what are the side effects, and they talk about other potential side effects. So here it is, important safety information. Elmeron should not be taken if you have hypersensitivity to the drug. Elmeron is a weak blood thinner, which may increase bleeding. Call your doctor if you'll be undergoing surgery, or if you're taking or will be taking an anticoagulant therapy. Tell your doctor if you're pregnant or if you have liver problems. The most common side effects are hair loss, diarrhea, nausea, blood in the stool, headache, rash, upset stomach, abnormal liver function tests, dizziness, and bruising. Where the hell's where's the discussion about eye problems?
Not there.
It's not there.
Any of the medical stuff.
And
none of the little things that you get at the pharmacy, nothing. There's nothing to tell you.
Right. And so I guess we could make this statement that the company simply did not make an attempt to monitor changes in vision in these patients over time. That's possible.
Yeah.
But should they have? Should they have? Yes, they should have. So the lawsuits are going to be really, really interesting. And I really wish you the best of luck, and we will keep you posted. I'll keep you posted on anything I hear. You know me, I believe in full disclosure if at all possible. And I know that there are certain people who are furious with me for doing that.
Well, they shouldn't be, because you're doing your job and you're doing the right thing.
Well, so I wish you well, and I'm glad that we were able to.
Yeah, I know. Thanks.
Okay. All righty then. Let us go to Sherry. If you don't mind waiting, I'm going to come to Shell next, and then I'm going to come to you. Okay. All right, Shell.
Hi.
How are you doing?
I am doing okay. I've had long work weeks right now, so the weekend is my friend.
Okay, so how is work going?
It's going okay. There's a lot of stresses, but I got a new chair and I got some support for my tailbone because that's one of my issues.
Yes.
And
yes.
So I haven't quite seen much difference, but it's only been for about 3 days of this week. So
you're going to be, you have to use that over time for sure. Yeah.
But I'm doing about 60 hours a week right now. And it's, luckily I'm a supervisor, so I do have times to, if I have to go to the bathroom 20, 30 times, it's not a big deal. And I'm in the medical behavioral health clinic, so they understand.
Okay. So how about, have you changed? So what's your strategy on food then? In the morning before you go to work and snacking and eating lunch at work and then snacking, what are you doing?
I have to really force myself to eat before work because I'm up at 3:30 in the morning.
Girl.
And so sometimes I've only slept about 2 to 3 hours. And so it's just like the last thing I really want to do is eat. Ooh. So I try to have like hard-boiled eggs and string cheese just available.
Okay.
I seem to be able to tolerate them okay.
Okay.
I do have IBS as well, so
Okay.
sometimes I have to watch the dairy intake.
Right.
But I do okay with, I started getting the cage-free eggs. I didn't believe my nutritionist when she told me that it makes a difference. It makes a difference on my gut, I can tell you that.
Mm-hmm. Mm-hmm.
So I may start doing like organic milk or something, see if that.
Yeah,
But-
I only do organic eggs, and I don't do milk at all.
Okay.
I do a mocha mix, or I do coconut milk. I don't do dairy milk at all.
I don't go for the coconut milk. I do like the oat milk, but
Mm-hmm.
there's something that I just don't feel that great after I drink it.
Yeah.
Not that I'm flaring in either the IBS or IC, but something just doesn't quite feel.
Okay.
So I drink that few and far between.
Okay. Well, I mean, you know what works in your body. Your job is to find those things that your body thrives on, right? And so it's about finding those foods that you could eat every day and that you would feel good eating those foods. And for me, it's 2 pieces of Ezekiel bread, maybe with some almond butter, or maybe with avocado, or rarely with a piece of Swiss cheese on it. Rarely. I must go for the avocado.
Avocado is my favorite.
Yeah. And then my snack is usually either popcorn or pea chips, or that I only eat 2 meals a day. I don't eat my 3 meals a day like I should. So, or Lay's potato chips, even though they're not organic, but there's something about Lay's potato chips that works perfectly in my stomach. So, right? Yeah, yeah. Well, has your pain a little bit better this week as compared to last week?
I don't feel like it's better, but I feel like now that I've been dealing with it for a week or 10 days, so
Okay.
it's just kind of become what it is.
Okay. And then in terms of you have to refresh my memory here. Hello, I am
That's
older.
okay.
My
I
short.
had the InterStim done.
That's
and
right.
I did meet with my urologist this week.
Oh, good. How'd that go?
She checked out like the incision site and everything, and she said she felt the warmth, but it wasn't on the incision site. It's actually at my tailbone. And so she thinks that it's just arthritis. So she had me turn off the InterStim for a week, and we arranged an appointment with the spine doctor or the orthopedist. I can't, but they're gonna look at the stuff that they did. Oh, she's cute.
Isn't she cute?
She's beautiful.
But the heat happened after the surgery.
Yeah, I know.
It's so disappointing that somebody would say it's arthritis when it's like, I didn't have this before I had the surgery.
Yeah. And she did at least recognize that. Like, she could see how frustrated I was. Like, I try really hard not to cry at the doctor. I'm like, okay, hold it in, because I know that I have to process through everything, but it's like, it was just, I am clearly frustrated over this because I'm trying to fix one thing, which is the urgency frequency, and now it seems like I have more issues outside of.
Did the heat by your tailbone go away when you stopped the InterStim?
No, it's still warm. It's not super tender from the outside, and the pain, I will say that the pain that was radiating up my spine
Yeah.
has gotten better.
Okay.
It's not going up so far.
Well, just be really with the track record shows that doctors discount patient stories about side effects.
Right.
And they just say, well, let's reprogram, let's reprogram, let's reprogram, let's do this, let's do that. Maybe it's arthritis, maybe it's this, maybe it's that. And it's like, ultimately, in the end, if you're getting shocked when you have a bowel movement, your inner stim is malfunctioning.
Right.
That is not normal. If you get
Right.
shocked when you go through security, your inner stim is malfunctioning.
And initially, that's what she had said. She's like, well, let's go through the programs. And it's like, you're not getting it. I don't want to go through the programs. And then I gave in to her. And so we had turned it completely off and go to the second program.
Mhm.
And literally, as soon as I started turning the thing up, it's like somebody was jabbing me in my vagina, and like, not just like tap, tap, tap. It was literally like, jab, you are hurting me.
Right. And how did she take that?
And she's like, okay, well, let's go to the next one. And I mean, we went through all the way to the 7.
Okay.
And well, I may have to program you a different program. And she's like, but for now, let's go ahead and turn it off till after you see your other doctor.
Well, I think that that's a good idea. And I mean, we just have had, now again, I'm not a doctor. I can't give you medical advice.
know.
All I can do is give you the context of the many other inner stim patients that I've worked with over the years. The squeaky wheel gets the grease. I think it's just really, really, really important that you keep saying, this doesn't feel right. This doesn't feel right. This doesn't feel right. And the more specific you can be about the symptoms you're having, the better. And I was thinking about you after last week. And the one thing that I didn't say to you last week that I meant to say to you is that if you decide it's not working for you, the sooner you get it out, the better. Because the longer it's in there, the more scar tissue develops over the leads, which makes it harder to remove.
Right. And I'm thinking about that as well, because I have issues with scar tissue. I've had to have a lot of have any of these feelings be permanent.
Right.
Or even semi-permanent. So,
well, I think the other thing you could do, honestly, is call Medtronic patient assistance and tell them your symptoms. And ask him about that. I have a sensation of heat at my tailbone. Have you seen that before? Because they're the ones who are going to have the archive, and then you can go through the MOD database and look for that too. But that's fairly new. And heat, to me, and it can be that, man, you're tough.
I kind of have to be. I've had over 20 surgeries. I've had 4 hip replacements. So, I mean, if I could get through all that, I could get through this. It's just, I didn't imagine it being so challenging.
Yeah. Well, I mean, clearly something changed when you had the surgery. So now they've got to figure out what it is and reverse it. If they have to. I mean, any treatment, quality of life is clearly not a treatment that's working, right?
Yeah.
And have your symptoms improved at all?
I do feel like they did in some aspects, and some of it, like nighttime, it's like I have that urgency that I had the frequency before, but now it's like, okay, you have to go and you have to go now. And to where it's like, I have to wear pads to bed, because if I don't, it's just a thing. So
no, hey man, I'm
not embarrassed amongst you guys, but like, I'm not really, my husband would not even think of it as a big deal.
Yeah.
But I still don't want it to happen.
Right, exactly. All right, will you keep me posted?
Appreciate you.
You're welcome. All right, all right. And Sherry, last but certainly not least, is Sherry. Girl, how are you? How is life?
I'm doing okay.
Good to see you. Look at that beautiful smile. Do you have one of your birds with you?
Yeah, actually, she's on my head, but you can't tell, can you?
I
Because of
can't.
the background. Okay, let me get her.
Oh,
See,
there.
She's gonna get on my hand. Okay, now I got her, and here I'm bringing her in front of me.
Oh, look at that.
There she is.
She's got a big, beautiful green parrot.
Yeah, she's a Senegal.
A Senegal parrot.
Orange, yellow on her chest.
Uh-huh.
But we can't turn her around. Turn around, Birdie. Okay, let me see.
Oh, look at her.
Yeah.
Oh, she's gorgeous.
I don't know. Can you see her?
I
Good.
can't. She's popping in and out, but because you're using
Yeah.
that special background, it's zeroing out. It's zeroing out any green. So,
Yeah.
well, how are you?
Okay. Okay. I'm fine. Okay. Here she is now.
Oh, there you
So-
go. That's much better.
But I can't see you now.
Oh, well, nothing
Okay.
changed on
X
my end.
out- Oh, I had to X out of that menu. So yeah, I X'd out of the menu. But anyway, this is Bridgie.
Hello, Bridgie.
And Bridgie, she talks. You know, she's a talker.
Aw. Hi,
I
Bridgie.
put on makeup and she keeps staring at me. So I got mascara on and some lipstick and face makeup. So she keeps staring at me.
All right. Well, how are you feeling? How is Friday?
I wanted to talk to you because I wanted to tell you that on Wednesday, I'm
Okay.
having another cystoscopy with hydrodistension
Okay.
with a new doctor.
Okay.
And he said he's going to really take a look. And he said he's going to fix anything that he sees is a problem, not just patch me back up.
Okay. So make
And-
sure he will take pictures for you. You
Okay,
want
yes.
pictures, video or pictures.
Right. And he's going to do that. And
Okay.
also, and this is what I'm not familiar with, he's going to inject my pelvic floor with lidocaine gel. Is that okay? It's not like Botox where it's inside.
Well,
the bladder, is it?
they will, what they will do is they will inject a muscle knot with lidocaine. It's called the trigger point injection so that
Yeah,
they can
trigger points.
so that they can work it. When you numb the muscle knot, it takes the pain away. So now you can get in there and work on it without
But
the
he didn't
patient
mention
trying.
physical therapy. He just said that this will numb me for a while.
Well, I mean,
But I-
trigger point injections are fairly commonly done. So,
Yeah.
you know,
I do expect to go to physical therapy though, but I'm waiting on the virus to calm down. you
right.
know.
Yeah. Another
Everybody is.
3 to 4 months, things might be better as long as the variants don't pick up. The thing with lidocaine is that you have to understand that lidocaine, if it gets into the bloodstream, can be quite dangerous. And I don't know if you remember
Right.
in Florida years ago, they were doing a lot of liposuction. And so what they would do is they do the liposuction and then they would put lidocaine cream all over the skin and then they wrapped them up with plastic wrap. And a couple of women died because
Yeah.
so much lidocaine got into their bloodstream it stopped their heart.
Yeah, I've read about that. That
Yeah.
you can't have it in too much in the same spot.
Right. So
Or
you
it messes with
so
the plasma.
you have to be very very cautious with lidocaine, but if he's done it before, hopefully,
Yes.
and he won't.
And he said it's going to be spread out. It's not all in one place.
Okay.
And so I'm hoping it's at least not like the Botox where I'm not going to be able to pee for a while if he hits a nerve. I hope it's not like that. Because
Well-
that's on the inside of the bladder, isn't it?
Yeah, that's in the bladder wall.
Mhm.
It'll be an interesting experiment. I mean, it'd be interesting to see if your symptoms all go away by doing the muscle therapy, then we know your muscles are the dominant problem. Now we got to figure out what the hell is keeping your muscles so tight, right?
No, I
It's kind of your wall. If we can put a salt solution in there, at which point patients will or you can put lidocaine in it. If you put lidocaine in it and it turns the symptoms off, then we know the bladder wall is probably the source of the pain. So we call that an anesthetic challenge. And it kind of sounds like he's doing something similar with the muscles, kind of an anesthetic challenge with the muscles.
And he says he has more tricks up his sleeve. So he's supposed to be very highly rated here in data.
Okay. Well, it'll be interesting. I think you need to know what he's doing. You need to make sure that he tells you exactly what he's doing, what the pros, what the cons are, what the risks are versus the benefits. And most importantly, having pictures before and after is so important. It's important for you to see what he's doing, but it's also important for you to have that in your medical records so that if you you can show the other doctor what this
Yeah.
doctor saw. So video is great, but you getting lots of pictures if possible.
When I had my last one done, I think I had it in 2019, and the hydro distension.
Yeah.
And I was trying to wake up from the anesthesia, and I was barely awake.
Yeah.
And I kept drifting back off, I wasn't even ready yet. And I asked him, I said, did he find some Hundreds Lesions? Or I was saying that, trying to say that.
Yeah.
And they said, no, none were found. And I started crying.
No.
I started crying, and the only thing I could associate that with is because I felt like I wasn't going to get any better because anything to find to treat.
Yeah, but I understand where you're going with that, but to me, I interpret that as fantastic news that if they look in your bladder and they find nothing wrong with your bladder, then fantastic. Then we need to stop looking at the bladder and look outside of the bladder or look at.
I was just trying to find the source.
Well, and so he's kind of doing that with the lidocaine injections, the trigger point injections in your muscles. That will potentially reveal any interesting muscle issues. So,
right.
but
I think childbirth was a problem for me, pushing.
Yeah.
And I had prolapses, and I had my bladder pinned up. I had my uterus taken out.
Well, there you go. You had a bladder suspension. So your bladder's already taken a beating. Your muscles have already taken a beating because you had a prolapse and then you had a suspension surgery. So, that just really kind of opens the door to this being really driven by kind of long-term muscle dysfunction, muscle trauma.
Right. Also, I had endometriosis in the late 80s when I had my hysterectomy.
Yeah.
And they cleaned it off of my ureters.
Yeah.
And my intestines. But I'm just kind of wondering if I have some still around my bladder area. And I know it's dormant because I don't have ovaries.
Right.
But it could still be scar tissue that's affecting me, couldn't it?
Yeah, possibly. If you've got some tight adhesions down there that's interfering with blood flow, blood distribution, maybe compromising a nerve. Sure.
Yeah.
Sure.
Okay.
So, but the hydrodistension won't reveal that. What would reveal that would be a laparoscopy or a sonogram. So.
Right. And that's my next thing is I've got to get an A and P repair. That's an anterior and posterior repair for my
Cystocele
and cystocele and rectocele.
Yeah.
And I'm gonna get her on 1, 2, 3. I have to do 1, 2, 3 fly. So because I still have prolapses and I have a big bulge inside my vagina when I've got to go to the bathroom, and it goes into that sac where it's prolapse, and it won't come all the way out of me. So I'm miserable at least a couple of times a week where I'm not defecating like I should be.
Yeah. Well, I have a partial prolapse there too. And, pushing, if you have to use your finger to push your finger against your perineum to try to get stool out.
Yeah.
I do too, And, with that is just if I get dehydrated and I'm or not eating enough fiber, if my stool is in rocks, is in small rocks, man,
that's what mine is like most of the time.
I know. It's just like it's just finding that magic number of having a normal bowel movement instead of these little hard rocks is hard.
One time I thought I was emptying and it never even came out. What it did was it built up in the very bottom, on the top of my bottom. Behind me, in my coccyx area. It landed up there somehow. I don't know how that happened.
Yeah, we call that packing, and it's called packing. So 25 grams of fiber a day. You and I have to do that. So how many grams of fiber have I eaten today so far? None. 0. I am for fiber intake. I have had
I had
0
that
grams of
too.
the only thing I've eaten today is a coconut milk yogurt.
I had some cereal. So, the Quaker, what do you call that? Nutty granola stuff.
I say I can't
So-
do that stuff. It just makes me
I know.
nauseous all
Yeah.
day. So obviously for dinner tonight, I'm going to have a lot of green peas or beans. 13
Yeah.
13 to 16
I-
grams of fiber, and then I will probably have Ezekiel bread French toast for dinner. For dessert. That will be another 6 or 8 grams of fiber. Your parent just
Hello,
went red.
Ricky.
So that's what we just all got, ladies, gentlemen. Y'all know what we all are there now. 20s, things are a little bit different. When you're older, seriously, that fiber matters.
I know. I haven't tried that Ezekiel bread. It sounds like it's really good.
Oh, it's wonderful. It's wonderful.
Yeah. Hey, I just got diagnosed with diabetes. So
Wonderful. No artificial sugars, hon. Don't do the artificial sugars. Bladder. So,
okay.
all right, hon. Well, listen, great connecting
Okay.
with you. It now
Okay.
says YouTube is getting it. Okay. Well, anyway, it's time to shut
Okay.
down Zoom. So I'm going to say goodbye.
Thank
Let's
you.
keep in touch.
Thank
Okay.
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 Bye-bye.
Bye-bye. All right. Zoom is over. Who knew we would be talking about all sorts of things today? Right? Like, I have no shame. If you want to know what I do, I have no shame telling you, because I figure we're all in this together, and I don't like secrets. I don't like the dirty secrets that we don't tell each other. We need support. And you know who really suffers? I got to tell you this. Kathy says Miralax, the best medication to get some movement. It is, hon. Yeah, it is. Absolutely. Aaron says, I try my best with heating pad, ice meds. That's to manage pain. So I'm on 2 different computers right now because Facebook, how's the stream been? Has it stopped and started in the last half hour? Just out of curiosity. Lally says, I have told the doctor I never can empty on my own after my hydrodistension, but they don't want to do it. I'm crying and have to take over the entire recovery room. Then I end up with a catheter for days, and the staff will feel stupid when they see how full my blood. Girl, yeah, you'd be amazed. You have to understand that whenever they anesthetize you, there are a variety of different anesthetics that they can use. Some are very strong that will silence nerves for a long period of time. Others are very, very short. And so I remember when I had my laparoscopy, and you can tell allergies are bad, guys, right now. Hay fever is ridiculous, which is why I keep scratching my nose. So I apologize for that. When I had my laparoscopy to rule out endometriosis in September of 1993, and I begged to do that, they sent me home without me being able to pee. And I did not pee for like 10 hours. I didn't urinate until like midnight that night, and I was in agony. And so when I had my whole uterine cancer thing going on 3 years ago, for the DNC, when I went in, I said to the anesthesiologist, I said, listen, I only have one goal here. I don't want to remember anything, and I need to be able to pee within 15 minutes of me waking up in the recovery room. He goes, I know exactly what to do here. I know I can make that happen, Jill. How? He goes, propofol. Propofol is an anesthetic that knocks you out fast and it wakes you up fast. And so even when they did my hysterectomy, I brought it up and I said, I need to be able to pee afterwards. And they said, well, we can't guarantee that. We use anesthetics that will really silence those nerves for several hours. And I said, I don't want you to do that. I want to be able to pee within 30 minutes, even of my hysterectomy. And he goes, okay. And they used more propofol and they used less of the other long-term stuff. And by golly, I could pee I was in the car on the way home, an hour after waking up in the recovery room for that hysterectomy. Insane. It's insane how quickly they send you home now. I mean, like they woke me up. I woke up in the recovery room. She, wakes me up. She goes, "Are you ready to put your clothes on?" I'm just like, "No, no." I go back to bed. Then she comes back 20 minutes later. "Jill, are you clothes on?" I'm like, "No." Well, I said, "But I need to go to the bathroom." She goes, "Great. We'll put your clothes on when you're in the bathroom." So, they hobble over to the bathroom, and by golly, she follows me into the bathroom. I sit down, I pee, I stand up. She whips my dress over my head. I wore a long tank dress, and she's like, "Great, you're ready to go home." And I'm like going, "What is happening to me? What is this? This is crazy." And she put me back in the wheelchair, back to my bed, and she goes, "I've called your sister. She'll be ready for you in 10 minutes. Pack up. We're sending you home." I'm like going, "What are you doing?" In the old days, 20 years ago, you might have spent the night in the hospital. Now it's like, man, slam bam, thank you, ma'am. You are done and out. And yeah, anyway. Okay, so the one takeaway home point of this is, guys, do not follow my example. Please eat fiber in the morning. You got 25 grams of fiber a day. Come on, you got to do it. We have to do it. For a man, it's 30 to 35 grams of fiber a day to have normal bowel movements. SPX says, "Have I read Dr. Malone's book?" I've started it. I had to get my magazine done, but I do have it, and I have started it. Sheila Girl says, "Bothers me that my gyno was raving about Elmeron, saying some of her patients have done so well for years that she scoffed at the eye issue." Well, it's almost malpractice now for a doctor to minimize what is a new clear FDA warning about eye disease. I mean, the new FDA warning on Elmeron is significant. It is serious. And the FDA would not have put that warning on that medication if they did not have proof. And we now have many studies showing pigmentary maculopathy. And the challenge, Surly Girl, the challenge here is it was a misunderstanding that when the Emory eye researchers put out their first article on it, they published what's called a case series. And it was basically the findings of 6 patients. And the purpose of the article was to demonstrate the damage. It's like, here are 6 patients, each of whom have visible damage to their eyes. But what happened is both patients and doctors went, "Well, it's just 6 patients. It's no big deal." The paper said nothing about population. The purpose of the paper, the case series, was to show the damage happening in multiple patients. So other people inferred population data from that 6 studies. And so I think our survey was the first to create wide-scale population data. But there are problems with my survey too, because my survey does not rule out, it asks, are you taking Elmeron? Have you had retinal disease? Are you under the care of a retinal specialist? But my survey does not rule out genetic macular issues. But so in the IC Network survey of our 2,000 plus patients, I just looked at it again last week, 54% of Elmeron users report retinal disease. 54. 54%. That's stunning data. But in that group are going to be some genetic patients. And so the first population-based study was done by a doctor here in Northern California at Kaiser Permanente. He was a young doctor who was very interested in it. And so he did a survey of patients who who had past tense used Elmeron for a period of time and asked them to come in and have their eyes examined. And he found 20%. But the flaw in his study is that they were not looking at current users. They were looking at past users. So we need more population data on this. So we've got the 54% of my informal unpublished study. Well, no, I can't say that because it was submitted to the FDA. The FDA accepted it. I mean, Phil Hanno, the chairman of the AUA committee from the on IC, said it was an outstanding work, asked me to send it to the FDA. And that's one of the reasons why we got the warning label on it, was based on our data. So our data is good data. But anyway. So Cirla Girl, what you should do is on our main website, I have a right on the front page, I've got a section, the little blue boxes underneath the main picture. One is our transitioning from Elmeron guide, and the other one is our Elmeron Eye Information Center. I would go there and I would print out the link on the FDA warning and send that to your doctor and say, this is what the FDA says. I mean, once you're at the FDA warning level, you can't throw it out. You just can't throw it out. You can't minimize it. It's big. Shirley, thank you for the 50 stars. I really appreciate that. Sylvian says, I'm so scared I will go blind after taking Elmeron for 18 years, and now I'm dealing with eye damage. It's heartbreaking. Honey, just remember that in our study, 46% were not showing eye issues. Everybody's different. We call this the snowflake principle. Not everybody's the same. Everybody has different reactions to medications and stuff like that. So we have trends, but you never know. So carry hope in your heart. And I really hope you'll come to the Zoom meeting on Wednesday and hear what the attorneys have to say, because you should be represented now and maybe consider participating in one of these lawsuits. Anne says, what other medications are they giving to us now that are going to cause us traumatic injury in the future? The only other thing, so remember, we just don't have a lot of medications approved for IC anyway. There are only 2 medications approved for IC, oral Elmeron, which is now basically done, and then DMSO as a bladder installation, which is all now fairly done, and we just don't use that very much either. And our subtyping, we now have the potential of curing people if we understand what your unique variant of IC is, right? And so I use the Chris Payne subtyping system. In his system, he has 5 fundamental variants for IC. So let's go through these real quick. Not every, let me just say that this is where things get so confusing when you're in an online support group, because you hear all these terrible stories and you're like going, oh my God, I don't want to be that. What if that's going to happen to me? And you really have to understand that there are huge differences in this IC patient population. 20 years ago, they thought this was a bladder disease, an incurable bladder disease. We don't think that anymore. We think of IC as a pelvic pain syndrome. Why? Because other structures are also involved in the pelvis for many of us, right? And so today, a diagnosis is, we try to make a much more refined, individualized diagnosis. So, and at the top levels of the IC research community, they've been exploring this for 15 years now. So in Europe, if you're in Europe, there are 12 core variants of IC. In Canada, they use a system called Input to create a customized diagnostic and treatment protocol for you, or customized treatment protocol. In the United States, we don't have a nationally agreed upon system, but I use a system that was created by Dr. Christopher Payne. And remember, I'm simulcasting. He ran the IC research program at Stanford University for over 20 years. He also chaired National Institutes of Health IC meetings. So the guy knows his stuff. And when he proposed his subtyping system, he did it in a really provocative way, because he said, we should treat IC patients like cancer patients. And we're like going, oh my God, why would you say cancer and scare people? That's how I felt about it. It's like, oh my God, don't say cancer and scare people. But when you actually read the article, that's not what he's saying. What he's saying is, when somebody's diagnosed with cancer, they don't just say you have cancer. They say you have cancer of the left breast that is estrogen dependent, type 1, 2, 3. They give you a really, really specific diagnosis. So, or for me, I had complex endometrial hyperplasia with atypia and a vague architectural complex, which was early uterine cancer. So, when you get a specific diagnosis, you walk out of the doctor's office and you know what your treatment options are. You know what they are. And he argues very, very successfully that a diagnosis of IC is fairly meaningless, that you have no clue what to do after you're diagnosed with IC. You have no, quote, intuitive treatment pathway. So how do we give you an intuitive treatment pathway? We give it to you with a more specific diagnosis. And this is important. And this is where being in a real support group where you meet people is important, because that's how you see the diversity. Because for some of you, IC began in childhood. For others, IC began after menopause. Are you the same? No, you're not the same. For some of you, while for others, IC began after chemo. No, you're not. You're not. Your IC is not potentially the same as my IC. And it's these broad strokes of people saying everybody has bladder disease or everybody has this or that. That is the ultimate failure. Western medicine fails the IC patient and the pelvic pain patient because doctors like to stay in their box. Urologists like to stay in the urinary tract. Gynecologists like to stay in the reproductive tract. Gastroenterologists like to stay in the bowel. And they don't look at relationships. And in the pelvis, it's all about relationships between the organs, the muscles, and the nerves. That's where we are today. And it's really exciting. So Dr. Payne starts out with 5 core variants, and then there are some subvariants. So let's talk about this. So here we have 5, using the Payne system, we've got 5 subtypes for IC. Okay. Subtype number 1, everybody in the world agrees that this is its own distinct patient group. Hundreds lesions. Hundreds lesions. And I showed a picture of them earlier. Big bloody wounds on the bladder wall. Hundreds lesions are probably the main disease process for people who have a disease. Because when you biopsy a Hundreds lesion, it is filled with inflammation. You biopsy my bladder, there's no inflammation. I'm an IC patient, no doubt about that, but I have no inflammation. I got a baby bladder. I got a perfect bladder. You look at my bladder, there is nothing wrong with my bladder. Nothing wrong. Whereas if you look at the bladder of a Hundreds lesion patient, where'd my picture go? Here it is. Here you go. This is very different. And again, you guys, I apologize. I'm on 2 computers here because we have problems with our connection. So notice the center red spot. Notice the center red spot. Notice the bleeding. Hundreds lesions bleed profusely. If you are a peeing blood, you have a pink urine or red blood clots in your toilet bowl. That is deeply concerning. That is not normal. And you have to figure out what the hell is bleeding. That is a visit to your doctor, a visit to urgent care. And for some of you, that's because you have Hundreds lesions. These bleed so profusely, they call it a waterfall effect when they stretch the bladder. So we now know, we all now have a clue what's causing the Hundreds lesions. We think it's the Polyoma Bk virus. as one of a couple of viruses. We know that viral infections can infect the bladder wall. We actually now believe that COVID is infecting the bladder wall in some patients as well. We know it's infecting the kidneys in some patients. So the bladder can have a viral infection. The bladder can have a fungal infection as well as a bacterial infection. So this is its own unique group, and there's a very strong movement now to split Hundreds lesion patients out of IC completely. Actually, they would be the IC group. The rest of us would be the bladder pain, pelvic pain group. Okay. So Hundreds lesions require its own unique therapy. They have to be cauterized. They have to be injected with a steroid. And maybe we're going to get to the point where we're going to use an antiviral. I will tell you that the U.S. National Institute of Health was able to confirm the presence of polyoma virus last year. But they found a slightly different polyoma virus. They found Polyoma Bk, but they also found Polyoma JC. So this whole new world is opening to us with that use of this next generation urine testing. So that's subtype 1, Hundreds lesions. If you have Hundreds lesions, your bladder is going to be wicked sensitive. You got wounds in your bladder. You're going to be very diet sensitive, and you're going to need lesion-specific therapy and probably some pain care. And lesions can heal, and sometimes, but there's there's still mysteries. There's still mysteries about why lesions happen, but we're getting better. So let's go to the next subtype. The next subtype is bladder wall driven. Okay, bladder wall driven. The bladder, like any other part of the body, can be hurt. If you have pain as your bladder fills with urine that is relieved with urination, then that tells us your bladder wall is involved. It might be primary, but it's involved. If you have pain after you're done peeing, that's not your bladder wall. If you have pain before you pee, as your bladder's filling with urine, that is usually your bladder wall. So what can injure the bladder wall? Number one, chemicals. So these are the patients whose symptoms begin after chemotherapy. We call it chemocystitis. These are the patients whose symptoms begin because they have a terrible diet and they drink way too much coffee or soda or diet soda or use artificial sugar. Or these are the patients who have been exposed to another caustic aggressive chemical like ketamine. Ketamine, when used in quantity, is the equivalent of an industrial solvent to the urinary tract. It just dissolves tissue. It destroys tissue. Okay. So the bladder can be injured through a chemical exposure. So our therapy for this patient is to, number one, figure out what the hell the chemical is, and then try to modulate that. So for patients going through chemo, there's a new medication they can give you, which renders the irritating chemical neutral. So anytime you're going through chemo and you have bladder irritation, you wouldn't tell them immediately because they might be able to give you a medication that will stop that. If you're using ketamine, you gotta stop it. And there are some patients who refuse to stop it and lose their bladder, but that's, a recreational drug that can cause terrible damage. And sometimes it's a mystery as to what if there is a chemical exposure. If you work in mining, if you work in with a lot of chemicals, if you work with pesticides, things like that, those are all things that could play a role that you need to pay attention to. The second thing that we have to look at for bladder wall driven symptoms is the quality and health of your skin. Is it dry? If your vulva is dry and your vagina is dry, so is your urethra and so is your bladder. We call that the genitourinary syndrome of menopause. Your bladder needs estrogen to produce that nice thick coating of mucus. But, unfortunately, so when you're young and you have lots of estrogen, you can get away with a lot because your bladder has a lot of mucus. When you're older, you have much less estrogen, much less mucus, and your bladder's ability to defend itself is now compromised. It's just compromised. So for these patients, our therapeutic priority is probably going to be to try to give those tissues some estrogen. And that's a discussion you have to have with your doctor. I have a video on our website called the Estrogen Chat. The third, and again, that's not a disease. That's aging. That's estrogen atrophy. Don't think of that as a disease. If your vulva's dry, that's not a disease. You're getting freaking older. Me too. It is what it is. The third thing that we look at in the bladder wall driven category, like infection, because it happens. The question is, what kind of infection could it be? And that's where the U.S. National Institutes of Health has done some phenomenal work. Because yes, there are people out there who are saying everybody has a chronic bacterial infection. But guess what? What our government has found, our supreme, outstanding MAP research network, one of the best research teams in the world, Candida infections, fungal infections, about 6 years ago. Could your flare be caused by not because, and not just one species? There are several species of Candida that can infect the urinary tract. So what causes Candida to grow and become dominant? Antibiotic use. Can you name one group of patients who's been massively overexposed to antibiotics? Yes, us, the lower urinary tract patients. We've taken a hell of a lot of antibiotics over the years. So it shouldn't come as that much of a surprise that some of us have Candida infections. Chronic, long-term Candida infections. And the challenge, a lot of Candida is drug resistant now. So if you look at the Center for Disease Control list of the top 10 drug resistant threats to mankind, 9 are bacteria and 1 is Candida. This is where next generation urine testing is really helpful because it will help you determine if you have a Candida infection in your urine. I will tell you, as somebody who had one for 2 years from long-term antibiotic use, it was agonizing. Active fungus in the urinary tract is way more painful than you would expect. It was stunningly painful. And it took a long time to kill it. So if you find that you flare when you eat sugar or carbs, we have to look at Candida. All right. There's probably another subvariant in here related to hormones. That, this is a work in progress. Let's go to IC subtype 3. IC subtype 3 is, in my opinion, the biggest subtype, pelvic floor driven. These are the patients whose symptoms began after having a baby, falling on your tailbone, a history of athletics, a rape, a trauma, abuse, a birth defect. So if your symptoms began because after you fell off a horse, after you rode a bike, after a long motorcycle ride, after having a baby where you suffered a muscle injury, we have to look at the pelvic floor. Because here's the issue. So here are your pelvic floor muscles right here. So here's your pelvic cavity. And there's a lot of muscles in here because these are the muscles that help you open your knees and close your knees. These are the muscles that help you walk, they keep you upright. There's a lot of responsibility in these pelvic floor muscles. Pelvic floor muscles, there's shallow, mid-level, and deep. And so if I stick my finger in my model here, look, I've got my finger all the way in here, the deepest muscles right here, right? And I want you to notice their proximity to the tailbone. You notice that? It's stunning. After a tailbone injury, or they have a tailbone injury. I'm shocked. I'm shocked by the number of you that have. I had a tailbone injury in the 7th grade. I absolutely believe that played a role in me. So if this tailbone has healed out of position, if it doesn't have the correct curve in it, if it's instead of being straight, it's to the left or right, that's going to tweak these pelvic floor muscles. But the other thing I want you to see about the muscles is that they're flat. Can you see that? Can you see that they go along the bone? See that? So when they're at their natural position, they're flat. When they get tight, they lift up and tighten. They get very dense. So now I want you to look at this. So I want you to imagine that your muscles, let's say that yours began with a trauma, and your pelvic, and they've lifted. They're tense. They're squeezing. They're pulling up off of the. So let's look and see what that's going to influence. So the first thing we're going to do is we're going to put in the uterus. Oh, see, hold on. I got to put the elevators on. I love this model, but it is a constant source of comedy as well. See, there's actually holes in it for the things to fit. All right. So let's go ahead and put in the uterus and the ovaries. Bam, done. Okay. Now think about what that muscles are doing now, potentially to that. Now let's put the bladder in. Hello, bladder. So look at that. Now we have the bladder. So now we can see why you have pain above your pubic bone, right? So here's your pubic bone. Here's your bladder. So if you have pain that is centered directly above your pubic bone, we're really looking at the bladder. But if you've got pain to the left, to the right, low, back, not the bladder. Now we got to throw in the bowel. So look at all this stuff happening in there. There's a lot of activity happening in this pelvic cavity. And now you've got freaking tight muscles that are reducing blood flow to the bladder, that are squeezing nerves. Remember, we had a patient earlier who was having some issues with sex and intimacy and clitoral issues. Well, guess what? If you got tight muscles squeezing your pudendal nerve, you're going to have PGAD. You're going to have PGAD, persistent genital arousal disorder, potentially. So when Dr. Payne wrote his subtyping system, he made the point of saying how cruel it is to tell patients that this is an incurable bladder disease, when in fact some of these subtypes are curable. And this subtype is curable with muscle work. And we knew this in 2008. You go back 100 years and you look at journal articles published on IC, you have doctors describing muscles so tight they look like piano strings. They feel like tight piano strings. But urologists play in their box, the urinary tract. They never went, oh, could these muscles be part of the problem? And it was a physical therapist who back in like 2002 and 2003 started coming to IC meetings and saying, guys, let's work with the muscles and see what happens. And she was doing it and she was having success. And they laughed at her. They walked out of the room when she started talking. I was there. I saw it. You want to talk disrespect? That woman took a lot of disrespect from urologists who didn't believe muscles played a role. Ironically, she now teaches them at the American Urology Association meeting. She was able to convince the National Institutes of Health to do a pelvic floor muscle therapy study with IC. And what do you think happened? It was stunningly successful. That was published in 2008. When that study came out, the IC world was turned on its head. Because if IC were a bladder disease, muscle therapy wouldn't help. Conversely, gee, if muscle therapy works, maybe muscles are part of the problem. There was a doctor who published a paper last year in which he believed that the majority of these patients were struggling with something called ischemia, oxygen deprivation, blood deprivation. That when you have a tight muscle, look at if you squeeze your skin, look at what happens. It turns white because when you squeeze it, you're driving the blood flow away. Well, tight muscles are doing this to your bladder and to the other organs down there. We have to restore blood flow. The therapeutic priority for somebody with pelvic floor dysfunction is to restore proper blood flow. How do we do that? We get the muscles to release. Muscle work. We have to get the muscles down flat on the bone, and we have to restore good blood flow, and we have to get rid of trigger points, because you can get a muscle knot in your pelvic floor. You ever have a muscle knot on your back and you look for somebody to push on it because when you push on it, it releases? Well, my friends, you can have a muscle knot here. And guess what? That's really hard to, it's really hard to push on unless you have a finger or a glass wand. That's why most people with glass wands do it. Shell says, can pubic symphysis dysfunction have an impact? Not on IC, on the pelvic floor. And the answer is yes. Colleen says, can I give you the Zoom meeting's over. We ended the Zoom meeting about 30 minutes ago. So we're done with Zoom today. So our therapeutic priority for this group of patients is to restore blood flow. And we do that with pelvic floor physical therapy. But even more importantly, it's what you do when you get home from physical therapy. The most important part of physical therapy is not the physical therapist working with you. It's what you do to recognize when your muscles are getting tight and acting on it. Like, and I was laying in bed this morning, I had the pulling sensation, which is my sensation when my muscles get tight. And I remember I was reading on my iPad for out of bed, and I remember laying there going, I should do that, and I didn't do that, and I can feel that now. I'm going to have to do that tonight. We have to be very proactive in this. A patient's is potentially curable. All right, let's go to our next subtype. Our next subtype is pudendal neuralgia. So think about it. So we've got bladder wall injury, pelvic floor injury, nerve injury. Pudendal neuralgia basically means that the pudendal nerve in your pelvis has become dysfunctional and or compromised. If you have pain when you sit down that is relieved by standing up, you have pudendal neuralgia. If you have pins and needles on your vulva around your rectum, you probably have pudendal neuralgia. If you've got persistent genital arousal disorder, where you feel this weird arousal sensation that's just incredibly creepy and disgusting, and you don't want to tell anybody about it because it hurts. I didn't tell my doctor about it. I wasn't going to make him think I had some sort of weird sex pain thing going on. Well, guess what? It's not that at all. That is called PGAD, and that's because the pudendal nerve gets compromised if the muscles are tight. So for this group of patients, our therapeutic priority is, number one, try to figure out where the damn nerve is compromised. And then number two, physical therapy to release the muscle that's doing it. And then number three, we're going to do things that calm nerves down. So they might have you do a topical lidocaine. Like I, a couple of years ago, had pins and needles along my vulva. And it took 6 months before it was correctly diagnosed with pudendal neuralgia. I never knew pudendal neuralgia could cause pins and needles along your vulva. I mean, I was really thinking of it in a very different way, like sciatica, shooting pain down your legs, or vibration. I thought I had vulvodynia. I thought it was a skin thing. And no, it wasn't. It was that my muscles had gotten tight again, and they were squeezing that nerve. And so the therapy for that was a lidocaine estrogen jelly to calm the nerves down on the skin, combined with pelvic floor physical therapy to release the muscles. And it worked. It worked. I mean, it worked in 3 or 4 appointments. It stopped. So there you go. The last subtype is also a very interesting subtype. I see subtype 5, or actually it's bladder pain syndrome subtype 5, central sensitization, also known as chronic overlapping pain conditions. So this is my primary subtype, okay? And so what does this mean? This means these are the patients who have very, very sensitive skin. Like, you can't wear wool, you can't wear textures, you can't do anything like that. Your skin is so freaking sensitive, it is ridiculous. You have a wicked sense of smell. You can smell things that other people cannot smell, and smells drive you absolutely bat blank crazy. It is so weird that a smell can trigger pain, but it does, because our nerves are wired different. Our nerves are easier to turn on. You may have visual sensitivity, where if there's a funky pattern in a carpet or a wallpaper, you have to close your eyes and turn away. You may have sound sensitivity, where some sounds are very, very vivid, and you can hear the littlest cat meowing 2 houses away. So what is this all about? Well, for some of us, it's inherited. My sister has this. My mother has this. My brother has this. My cousins have this. My aunt has this. My grandmother had that. My great-grandmother had that. You can inherit a more sensitive nervous system. Right. Shell, that's mine too. Right. That's my subtype 2. Subtype 5 primary, pelvic floor secondary. Okay. So hello, redhead. My family came from the Arctic Circle, pretty much. Northern Norway, northern Sweden. That's where I'm from. And if you go back 5,000 years ago, what were I mean, the bladder I have today was the bladder that was designed 5,000 years ago. That's true for you too. So what was happening 5,000 years ago in Norway and Sweden? Nothing. World's blandest diet. They were eating seals. They were eating whatever they could catch. And they only had fruit once a year. And usually it was just berries and maybe, I don't know, maybe apples. That's it. There was no chocolate. Chocolate came from Africa. No wonder chocolate's like poison in my body. My body doesn't know what the hell to do with chocolate. Whenever I eat chocolate, I get severe cramping. Caffeine. Caffeine comes from the equator around the world, Asia, etc. Latin America, Asia. Somebody, our nerves are so easy to trigger. Caffeine drives us crazy. If I have caffeine, I don't sleep for 2 days. And I shake. I already shake anyway. You guys have seen my tremor. I have a little tremor where I do this every now and then, right? Well, you should see me with caffeine. It's like, woo, you know, my nervous system is insane with caffeine because my nervous system is not built for a neurostimulant. Whereas you take somebody whose ancestors are from around the equator, they've had tens of thousands of years to adapt to that. I haven't. And that's where our global economy is very challenging in the sense that we are being exposed to things that perhaps our body simply doesn't know what to deal with. You know, your liver's job is to get rid of stuff that your body perceives as poison or that we've just got to break down. But sometimes the liver just doesn't know what to do, and it ends up leaving these toxins throughout our body, which is rough. Okay, so concept number 1 is sensitization can be inherited. It's a landscape. It's not a disease. I've always had sensitive skin. I could not use bubble bath as a kid because my skin was so sensitive. Neither could my sister, neither could my brother. So it is my job on a daily basis to protect my nervous system. And if those of you who are sensitive, you're already doing that. You probably don't have scented candles in your home. You're probably not using Febreze. You're probably doing all of that right now. We have to really clean up our environment and we have to protect our nervous system. The odds are too that you're not particularly happy in a big city. You're probably happier in the country, like I am. If you could see out my window, you'd see I live on a now burned hill, but I live in the hills, you know, and you put me in the city and I'm miserable. Too many smells, sounds. I mean, I can do the work, but I'm not happy. I want to leave. The other thing which causes central sensitization is injury to the nerves. And I've talked about that in the last couple of meetings. We call it that you have. So if you think of your nerves as a netting, think of it as a net. There are big nerves and there are little nerves. The littlest nerves are the nerves that have the tiniest diameter. We're talking tiny, tiny, tiny nerves. And they are the nerves in your skin. And their job is to communicate pain and to communicate temperature to the central nervous system. When, let's see, how do I want to say this? So that's the mechanism underneath the skin sensitivity, is that our small fibers in our skin are just stunningly, remarkably sensitive. But we also have small fibers in our bladder wall. We have small fibers in our bowel. We have small fibers in our stomach. So we now think that those also develop a malfunction, for lack of a better term, a neuropathy, for the lack of a better term. So what symptom would that be? That would be that false sense of fullness. You feel full even if you're empty. That sensation is coming from the alpha afferent nerves in your bladder wall and the small fiber, which are, I would assume, are small fibers in your bladder wall. So what causes fiber neuropathy if you haven't inherited it? Well, diabetes. If you have untreated diabetes, that damages nerves. Vitamin B12 deficiency. If you don't have enough B12, that's going to damage nerves. If you don't have enough copper, that's going to damage nerves. Or if you have too much B6, that's going to damage nerves. You know, there's people who say, eat a lot of vitamins. You want to take a lot of vitamins, you'll be healthy. No, they're wrong. If you do too much B6, which I see patients don't normally do, you could hurt yourself badly. I have an article on this in our next magazine. This doesn't have the picture on it yet. I mean, the typesetter has it. So what are the causes? So B12 deficiency, copper deficiency, or too much B6, B1, or E. If taken in excess, B6 can cause nerve damage. Okay, there you go. Some chemicals are quite toxic to the nervous system, especially chemotherapy. So what drives chemocystitis, we now know, is the chemicals in the chemo damage or irritate the small fibers, small fiber nerves. Or heavy metal exposure. So one of the things that they do if somebody works in industry is they will do a 24-hour urine test specifically to look at heavy metal contamination. Because if you're exposed to lead and mercury and other things like that, that could cause small fiber polyneuropathy or neuropathy. Some medications can cause neuropathy. And I hate to break it to you, but some of the medications we've all taken for bladder infections can cause neuropathy, like nitrofurantoin and fluoroquinolones, Cipros. Alcoholism can cause neuropathy. And of course, we now know that some viral infections can cause a neuropathy. My brother, who's 8 years older than me, had an outbreak of shingles on his back like 3 years ago. And he's a redhead too. He's got the sensitive skin too. Well, the shingles only lasted for 2 or 3 weeks. He's still taking gabapentin today for the post-viral neuralgia. So Lyme disease can cause a neuropathy. Herpes can cause a neuropathy. Chickenpox. Most of us have chickenpox, can cause some nerve damage. And HIV can cause. So what are the symptoms of small fiber neuropathy? Sensory disturbances like cold pain or tingling or pins and needles or burning pain. So remember, the small fibers convey temperature. So if you're feeling heat or cold, activity of that skin, like the littlest touch, something that should not touch pain, provoke pain, can provoke pain. It can cause you to feel like you have, like you're walking on a pebble in your shoe, even though there's no rock in your shoe. Night or during periods of rest, and they fluctuate. And that's when I feel the pins and needles in my skin more. I don't feel it during the day. I feel it at night when I'm trying to go to sleep. And again, when I start feeling that, I immediately go to something that has a nerve calming effect like Peora, PEA. What are the other symptoms of small fiber neuropathy? Fainting. If you're somebody you just faint randomly, or dry eyes, or dry mouth, or dry skin, or dizziness, or lightheadedness, or GI dysmotility, also known as gastroparesis. I have that, or I had that. Neurogenic bladder, erectile dysfunction, or interestingly, abnormal sweating. If you don't sweat normally, that might be a sign. So here's where this is really exciting. You know what? Information is power here. Shell says central sensitization is same as wind up. Yeah, kind of, sort of. That's a good question. So how many times have you gone to the doctor with pain and they go, I don't see anything? How many times has somebody said to you, it's got to be all in your head. I don't believe you. How many of you have been denied disability because there was no proof? There was no objective finding that there was something wrong with you. That's changed. That's changed. Because guess what? They can prove it. You know how they can prove that you've got small fiber neuropathy causing your symptoms? There's a little tiny down in your lower leg, 3 millimeters. Look at it under a microscope. No one can ever tell you that this is all in your head. No one can ever say there's nothing wrong with you. No one can ever say there's no proof. For the first time ever, we have the ability to get objective evidence to support our nerve pain. This is huge, guys. This is huge. Now, if you've got extensive frequency, urgency, and or pain, and you're applying for disability, and that doctor says, well, there's no proof, you give them a biopsy and look, doc, I've got small fiber polyneuropathy. Guess what? That's common. 66% of patients with chronic overlapping pain conditions have small fiber polyneuropathy. That means our nervous system isn't functioning normally. These are the symptoms. And guess what? Treatments are challenging. It's proof. It's objective evidence. Do you realize how exciting that is? We got to kick them in the balls. We shove this biopsy result down their throat. For anybody who says this is all in your head, because we can prove it now. And you know, I was talking with Dr. Elise Day, who's the author of one of the editors of Facing Pelvic Pain 2 weeks ago, and we were talking about this, and they're doing a lot of research now with small fiber neuropathy in their clinic. So she sent me a bunch of their work and articles and things like that, which is what I used to write this article for a magazine. And I wrote to her, I said, you know, as exciting as this is, I mean, this is huge. It breaks my heart for those patients in the last 50 or 100 years who were told it wasn't real, and who were referred for mental care, and who were denied pain care. Imagine having a neuropathy. Your nerves are literally malfunctioning. They're hot. You're being burned. And they told you it was all in your head, and they sent you home to suffer. For them, we fight. For you, we fight. So I always open up every meeting with, I don't want anybody to mess with you and tell you it's all in your head. So many good things. I mean, you need to carry hope in your heart here. We have made more breakthroughs in the last 5 to 6 years than we've made in 100 years. More patients are getting better because we understand these subtypes. There is hope. Information is power. Mickey says here, so happy. I had a hydrodestension cystoscopy on Thursday. This is probably my 12th or 13th. And for the first time, no biopsies or fulguration. My bladder has healed. And she says from all the herbs that she uses. Like to know more about that. And she says, I'm definitely IC subtype 5. It's because my mother on my maternal side is Norwegian, Finnish, and Scottish. So Mickey, it may be that what's happened is that the program that you're using is, rather than calming the bladder wall, it's actually calming nerves down throughout your body. I mean, that's possible. Isn't it great? This is so exciting. Now I got to figure, I have to convince Kaiser to do a biopsy on me. I have a good relationship with my dermatologist. I don't know if she would do it though, because I'm like the queen of the craziest reaction. I have the craziest freaking reaction to skin bites. The worst thing ever is no-see-ums. You guys know what a no-see-um is? A no-see-um is a microscopic biting insect that flies through your screens. It lives in wetlands. You cannot keep it out of your home. It flies through your screen. You have to keep your windows shut. You got to keep your air conditioner on to keep that wind circulating. When you're bit by a no-see-um, it's like being bitten by a hot needle. And you're like reading a book or watching TV, and it's like, what the hell was that? And there's nothing there. And no-see-ums, what they do is they go up your pant legs and up your sleeves. So if you're like this, they would just go right up this. They would go right into the skin underneath that. Holy hell. We had an outbreak of no-see-ums, a rare outbreak of no-see-ums a couple years ago. And I had one that was so bad that it became a volcano. I don't know if you can see this. Can you see this scar right here? Look at that scar. It's like 3 inches long. This one bite became cancer. And it wasn't a little cancer, it was a huge cancer. And they had to do the equivalent of Mohs surgery right here to get it all out. And they didn't even warn me. They just said, come on down, we need to take a little bit more. They walked me into the operating room, the dermatology operating room. And I like stop at the door and go, why am I here? And they go, oh, it's no problem. We're just going to take a little bit more. And I'm like, wait, why am I in this room? And she goes, well, we didn't want to alarm you, but we're actually going to take a lot. And my incision was this long, like 3 to 4 inches. And I walked out hysterical. I walked to my car. I was shaking. And I called my sister and I burst into tears. And I was like, you're not going to believe what they just did. Life is perilous. God, we all have stories. I know you're here. I'm probably boring you with my stories, but SPX says, do I have Instagram? No. I have a hard enough time keeping up to date with Twitter and Facebook and Pinterest. All right. Well, listen, you know what, man, I can talk forever. And again, as you know, I'm willing to talk about anything. So last call for questions. We have been going now for almost 4 hours. And I'm happy to take any more questions. Anybody got any last questions? Otherwise, we will call it here. My skin is very itchy today because allergies, right? Once allergies pick up, bam, then my head gets all irritated, and that's why I'm scratching all the time or just touching. Last call for questions. YouTube, Facebook. How has it been? How's this great stream been in the last 30 minutes? Stopping and starting? Have you had fewer delays, or has it been better? Because we had to stop our stream on Comcast and we started it on AT&T. Comcast was a wreck on Facebook. Kathy says, can you have many subtypes? Yeah, but I mean, there's cause and effect. Okay, so like if you have Hundreds lesions, your bladder is screaming in pain, your muscles are going to get tight as a reflex. So Hundreds lesion patients are going to be subtype 1, subtype 3. If you have bladder wall driven, and your bladder screaming in pain, you're going to have tight muscles in response to that pain. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. They're both involved, but one is normally primary and one is normally secondary. So if your symptoms began after chemotherapy, or you had a terrible, also irritated, and if we calm your bladder, you should calm down, right? And your muscles should release. But it's the muscle injury patient that is in the much more difficult situation, because with a muscle injury patient, let's say you fell on your tailbone, or you were out riding a horse. Now, the next day or 2 days later, you have frequency urgency. You think you have infection. You call the doctor and you say, hey, man, I have infection. The doctor goes, okay, and they give you antibiotics. They don't work. You go back to the doctor. And the doctor goes, oh, maybe you've got overactive bladder. They maybe tell you to stop drinking caffeine or soda. They give you ditropan or Detrol or Mibratrix. Doesn't work. 3 months later, 6 months later, you go back to the doctor. You're exhausted. You're not sleeping at night. Doctor, nothing's worked. The doctor goes, man, I hate to break it to you, but I think you've got interstitial cystitis. It is this incurable bladder disease. There's no good treatments. Here's a diet. Here's Elmeron. Be on your way. And you do it. You like fall down the rabbit hole of IC. Okay, I've got IC. I've got this incurable disease. You're on Facebook. You're reading all these horrible stories. You do bladder therapies. You take Elmeron for years. You don't get better. Why? Why? Because for a lot of you, your bladder is a secondary victim of another. You could have a fibroid tumor pushing on your bladder. You could have endometriosis on your bladder. You could have a Tarlov cyst. Coming out of your spinal cord. Right back here. You could get a cyst of spinal fluid emerging from your sacrum, pushing on the nerves to your bladder. That could explain it. You could have a prolapse. There are so many other things that could trigger these symptoms. And so that's what the AUA tried to address when they say in their guidelines, if a patient is not responding to therapy, if a patient is getting worse rather than better, for God's sake, take a freaking step back and reconsider the diagnosis. Don't keep giving that patient Elmeron for 10, 15, 20 years. If it's not working, stop, take a step back, look at the diagnosis again, and let's review some other things. And that's where, guys, this book is phenomenal, because this book basically goes over everything that can trigger IC symptoms that's not a bladder problem. There's chapters in here on the gut. There's chapters in here on the reproductive tract. There are chapters in here on muscles, on bones, on nerves, on autoimmune diseases. If you truly don't know what the hell is wrong with you, except you know that you have a fairly normal bladder and you're not responding to bladder therapies, for God's sake, get this book. It's free on Kindle Unlimited. No excuses. It's free. And go through these chapters and think back in time. Like a patient I was working with on Friday. We're trying to find, as I say, when you actually spend time with patients talking to them and you go back in time to when their symptoms began, look for trauma. How many of you fell on your tailbones? Or were a victim of bullying, which can also cause a whole cascade of reactions? Or maybe there's a birth defect. Who knows? But the point is, you have to remember that in the pelvic cavity, when you've got a problem in the pelvic cavity, you cannot play in one sandbox. You have to look at all the sandboxes. You have to look at the bladder and the urinary tract. You have to look at the reproductive system. That goes for men too. You have to look at the gut. You have to look at the muscles. You have to look at the nerves. You have to look at the blood vessels to solve the mystery of why you are getting up all night. It is weird that muscles can cause bladder symptoms, but they can. It is weird that fibroid tumors can cause bladder symptoms, but they can. It is weird that having a bad foot and you not walking normally can create long-term pelvic floor dysfunction and tension, which will eventually affect your bladder. It happens. It's like peeling an onion. It's like peeling an onion. The other book, for those of you who you sustained muscle injury, or you were an athlete, or you were in an accident, this is the book. This is the book, Breaking Through Chronic Pelvic Pain. It is a masterclass in pelvic anatomy. It will teach you as much as everything you need to understand everything that will mess with the pelvis. And he's the one who says that Western medicine fails a pelvic pain patient. You know, one of the things that he talks in here, there's great patient success stories in here. I mean, there's so many in here. He talks about, I opened it right up to tailbone pain, coccygodynia. Tailbone injuries can have profound repercussions, including anxiety, depression, panic attack. Therefore, my first step in evaluating patients who are experiencing anxiety or depression is to check for tailbone tenderness. Kind of makes sense because the tailbone does encompass part of the spinal cord and the nervous system. Patients with pelvic floor dysfunction and attempt to keep off their painful bottoms sit slumped on their tailbones. This posture causes trigger points to form in the coccygeus and the coccygeus muscles, adding insult to injury. This book is a bombshell. But here's something that always, so like, have you ever had bowel pain so severe sitting on the toilet that you literally cannot move? Like you're just frozen. You're just frozen in pain. I have had that a few times, and I associated that with IBS. If I were having an IBS attack, that lower left-hand quadrant and the last couple of inches of my rectum, man, when that spasms, holy hell, I call them bend over and screamers. That's a real thing. It's called proctalgia fugax, the ultimate anorectal pain. They are recurrent episodes of pain localized to the lower rectum. They can last from seconds to minutes, but in between, everything's fine. They just happen sporadically. An estimated 14% of the population has this disorder, although the incidence is higher in patients with GI problems. The attacks are sporadic, quickly and completely resolve. Many who experience them may not seek medical care. This leads me to suspect that 14% is an understatement. And so what causes it? So it was discussed in 1883. And ultimately, in the end, it's a trigger point. It's a muscle trigger point. The mainstream medical community considers proctalgia fugax to be poorly understood benign disorder of the GI tract that can be controlled with medications, particularly antispasmodics. However, based on my clinical findings over the years, I feel comfortable declaring pudendal neuralgia and or spasm trigger points of the pelvic floors, particularly the puborectalis muscle, to be the clear cause of this rectal pain. So what triggers it? Sitting for long periods, sexual intercourse, extreme stress or anxiety, extreme physical exhaustion, constipation, or straining with bowel movements. Please do not strain. It's hard, but try not to. Or IBS, which produce a viscerosomatic reflex from the colon to the muscles of the pelvic floor. And that's exactly what I was having when I had these bend over and screamers. And so what's the treatment? Pelvic floor physical therapy and an evaluation of the pudendal nerve. Leslie, age 36, came to see me with a laundry list of symptoms and challenging history loaded with stressors. The sum total left her in a barely functional state. She complained of pain in her left hip and tailbone, lower abdomen, pubis, and upon questioning, pain in her toe joints and numbness of her little toes. She said the pain flared severely whenever she rode a mountain bike, forcing her to abandon this activity. That sitting and her job required long periods of sitting was painful, and that walking was sometimes very hard. She also reported suffering from urinary stress and urgent incontinence with the urge to void during intercourse, and that when holding back her urine, she felt pain throughout the pelvic region. Additionally, she related a history of painful constipation with intense straining, possibly related to high doses of narcotics she'd been taking. Finally, she described episodes of stunningly deep anorectal pain that lasted about 3 minutes, causing her to stop in her tracks, wait with her fists clenched, and catch her breath when they ended. These painful spasms became more frequent and severe to the point that where she feared she could not continue to work. 5 years prior to her consultation with me, Leslie had experienced pain with intercourse. The recommended treatment was a hysterectomy for fibroid tumors, along with a tummy tuck, after which she did well for a year. Then the abdominal pain began, and her doctors evidently thought it was psychosomatic. In her words, they made me feel like I was crazy. Nonetheless, an exploratory laparoscopy was performed and adhesions related to the surgeries were removed. This relieved the abdominal pain for 10 months, but then it returned and Leslie had yet another surgery. The most recent procedure revealed she had endometriosis. Upon examining Leslie, I found trigger points in her hip rotator, adductor, abdominal, and psoas muscles, and also in her abdominal scar, along with extreme pelvic floor muscle tension, particularly in her puborectalis. Also observed were biomechanical abnormalities that included hip height discrepancy, Morton's toe, bunions, and excessive pronations. Myofascial release of the tension and trigger points in the dysfunctional muscles and trigger point injections in the tender abdominal scar gave Leslie relief. After only a few treatments, she was able to decrease her pain medication by 50%. Her rectal spasms and other symptoms greatly improved, and she could walk comfortably for an hour 4 times a week. In fact, the last time I saw her, she was feeling so good, she confessed that she'd almost canceled her appointment. My examination that day revealed a few trigger points that required some additional attention. The pudendal nerve did not play a role in Leslie's case. Muscles, muscles, muscles. You cannot underestimate the importance of muscles for IC and for pelvic pain and all this sort of stuff. All right? All right, my friends. For 15 minutes a day, I need you to do something to calm and nurture your spirit. I'm probably going to go walk through my butterfly garden. For 15 minutes a day, I need you to do something for your bladder or your pelvic floor. For me, that means I'm going to do for 15 minutes, get my wand and work on my internal pelvic floor muscles tonight before I go to bed. For 15 minutes a day, I need you to do something for your noggin to improve your knowledge level. You've attended this meeting, so you're done for today, but tomorrow you got to start reading again. And for 15 minutes a day, I need you to do something that will make you laugh, because laughter modulates pain. Laughter modulates pain. If pain is accompanied by anxiety, your brain will intensify that pain. Pain that it's accompanied by laughter, your brain will minimize that pain. So please watch TikTok, watch videos, whatever, laugh. We got to get the laughter up there. No more hiding in your room with the drapes shut and the lights out, feeling sorry for yourself. Pick yourself up, open the drapes, get outside, let the sun shine in. Let's get this knowledge level up. And it's time to fight again. And you are not alone. You have hundreds of hundreds of thousands of brothers and sisters fighting right along with you. So if you're doing something hard, I want you to just pretend that I'm standing right next to you. Okay? Be bold, and mighty forces shall come to thy aid. All right, my friends. Be bold. I will see you again sometime this week. I think we're seeing here that AT&T is a win and Comcast is a fail when it comes to Facebook. But I'm going to do another, just Facebook only one this week. Maybe on Thursday. All right. Talk to you later. All right, guys. I'll see you later on YouTube. Y'all have a good one.